Thanks, Luke. And we are right at 9 o'clock, so I'm going to end the poll here. And I will share the results. So the majority of us don't know our community bystander CPR rate, which hopefully will show the importance of today. So what I want to do is start our conference. I would like to start here. Oops. All right, so here we go. So I'd like to welcome everyone to the Save My Heart Conference, Out of Hospital Cardiac Arrest, Moving Beyond COVID-19. My name is Jim Pribble, and I'll be the moderator for today's conference. Save My Heart Committee has put together a terrific lineup for today's, today's conference. As we all try to move beyond COVID, we realize the reality of Zoom fatigue. That is why we developed today's conference with many short presentations that will focus on two important links in the chain of out-of-hospital cardiac arrest survival. We want to focus on the two links, community response and EMS. Having a little bit of difficulty with my slides here, so I apologize. So a quick mention of today's logistics for the conference. Like I said before, the majority of today's fast-paced presentations will be 10 to 12 minutes in length, followed by 3 to 5 minutes for questions. We want this to be as interactive as possible, so your participation is key. This conference will utilize the chat function for all participants' questions. You can post a question anytime during the speaker presentation. The chat will be monitored, and at the end of the presentation, these questions will be asked to the speakers. We may not have time to answer all the questions due to the fast-paced nature of the conference that are posted in the chat, but be assured that all questions will be addressed by the speakers or Save My Heart leadership, and answers will be posted to our website shortly after the conclusion of the conference. The session today is recorded and will also be posted to the Save My Heart website. I want to make everyone aware of the discussion section that will occur following the main presentation. In the original agenda, there were breakout sessions, but we had to change it because of some Zoom issues to more of a discussion section. So at 11:45 a.m., these discussions will mirror our conference and focus on community response, which also includes 911 dispatch and telephone CPR, and EMS. These sessions will have a facilitator along with an expert panel in an open discussion to identify critical issues that we need to address to improve out-of-hospital cardiac arrest survival in the coming year. We need everyone to be involved in this, so please ask questions and post comments through the chat function so that we can use all the expertise at this conference and improve out-of-hospital cardiac arrest survival in the coming year. The conference is approved for 3.5 CEs. Just a reminder, to receive credit, you must attend the entire conference, and your EMS cheat sheet will be emailed to you within 10 days. Finally, each participant will be sent an email with a link to a survey about this conference. We would appreciate everyone filling this out and helping us better conferences in the future. Without further ado, how about on to the conference? I'd like to introduce our first speaker, Dr. Robert Newmeyer. He is professor and chair of emergency medicine at the University of Michigan, as well as one of the founders of Save My Heart. His first talk, out-of-hospital cardiac arrest, moving beyond COVID-19, will be presented here. And I'd like to stop sharing my slides, and Dr. Newmeyer, you can take over here.
All right, thank you. I'm going to go ahead and get my slides up. How does that look?
That looks great.
Okay, and you can hear me okay?
Your audio is perfect.
All right, thank you and welcome everyone. It's great to see such a wonderful turnout, 140 people on right now for our annual Save My Heart conference. And what I'm going to do, similar to what we've traditionally done, is at the beginning go over some of our 2020 data to try to set the stage for the discussions and how we can work together moving forward to optimize cardiac arrest outcomes. These are my disclosures. And just to remind everyone, the goals of Save My Heart, which we formed, I guess it's about 7 or 8 years ago, was to match the American Heart Association goals of doubling cardiac arrest survival in the state of Michigan by 2020. So we're now at 2020. So we're going to really assess our progress toward those goals. And also, as part of today's work and our work moving forward, is think about what our new goals will be beyond 2020. And with that goal of doubling cardiac arrest survival by 2020, we had the hope of saving 1 extra life every day. And in the system of care, as illustrated here by the American Heart Association algorithm, really it breaks down into bystander response, 911 dispatch, EMS, and hospital care. And both as an organization and in the data we're going to present, we'll look at those different components of the care as we try to improve our outcomes across the system of care. What we didn't plan for back 7 or 8 years ago when we created Save My Heart and set our 2020 goal was the COVID-19 pandemic. And this certainly in many ways has disrupted life in general, has disrupted medical care, has disrupted our EMS system, and disrupted our system of care for out-of-hospital cardiac arrest. This is the most recent data from the Johns Hopkins site illustrating that to date in the state of Michigan, if you look on the left column, 951,000 cases of COVID have been recorded. So we're approaching the 1 million mark. And in the upper right-hand corner, it shows to date, 19,000 deaths in the state of Michigan. And then if you look at the bottom corner, this is something that I think everyone's very familiar with, the different waves of new cases that were in the state of Michigan. Initially, we had our first wave in April, the second wave, which was very significant in December. And now we're just emerging from our third wave of high incidence of COVID infection. This graph illustrates total death rate in the state of Michigan comparing 2019 to 2020. So the black line is monthly deaths in 2019. The orange line is monthly deaths in 2020. And then the red line are deaths in 2020 specifically attributed to COVID-19. And you can see typically the monthly death rate is relatively stable at about 8,000 a month. And you can see in our initial peak in April, we had a significant rise up to 1,300 deaths with a resolution over the summer. And then with our secondary peak going into December, a significant rise, which very much matches the incidence of COVID-19 attributed death. But it's not completely all COVID cases. There was an 18% increase in total deaths in 2020, and 64% of those additional deaths are attributed to COVID-19. So there's still a third of those additional deaths might be attributed to other causes, such as disruption of medical care, delayed care, people being afraid to seek medical care for significant illnesses, and even disruption of the healthcare system and our own EMS system. The impact on EMS providers has been tremendous. And I just want to take a moment right now just to thank everyone involved in the entire system of care for their dedication and persistence and diligence during this time. It's been a very challenging time, especially early on when we had little knowledge about the disease process itself and how it's transmitted. We had trouble with accessing PPE. We had to change many protocols in order to protect our providers against aerosols and defining aerosol generating procedures. And again, it's amazing what we have been able to do and maintain in the midst of this in terms of the COVID pandemic. So just thank you everyone for all the service and work that you've done in the past year. So moving on to our CARES annual report, as you can imagine, we anticipated, and as you will see, we had some challenges in the year that resulted in some reversal of a lot of the progress that we've had in our cardiac arrest system of care. But I'll preface what I'm going to show you is that the changes that have occurred are less than what I actually expected, knowing what was going on in the past year. One thing that's most important is that we were able to maintain our data collection system. So this is a map of the regions that are involved in the CARES registry, and this map actually needs to be updated because there's more sites that are in red with full data submission than is listed here. And then the picture there is Terry Shields, who is our state coordinator, without which we would not be able to have this data that I'm about to present. We continue to have in 2020, 151 EMS agencies reporting, 116 hospitals reporting. If you look at the Michigan population relative to the CARES population covered, that's 88% of the state population, which is a just tremendous effort. And we had a significant increase in the number of treated cardiac arrests, 9,290, which calculates to incidence relative to the population of 107 EMS treated cardiac arrests per year. So looking at our specific data, one of the things that we were very concerned about was what would happen to bystander CPR rates. And as you can see here, we did see some decline in our bystander CPR rate year over year, but actually that decline was a lot less than expected. So just to orient everybody to these graphs, the black line is the national data, the red line is Michigan state data, and then the green star is what we had set back 7 or 8 years ago as our 2020 goal. So you can see we were making significant progress in our bystander CPR rate, a bit of a setback this past year, but not nearly as much as many expected. But we still are far from our 2020 goal. Similarly, bystander AED applied rate, we had significant growth over the past years since 2014, but in this past year, that's relatively plateaued without a significant decrease, which again, I think is a great accomplishment in the midst of the pandemic. ROSC rate was something that we did see a significant decline in. As you can see, since 2014, we were having some gradual progress, and we actually met the national average last year, or very close to that. But both nationally and in the state of Michigan, we did see a decline in our ROSC rate. And parallel to that, we did see a decline in our overall survival rate, similar to what was seen nationally, with our current overall survival rate shown here. There we go. And finally, our survival with good neurologic function similarly declined over the past year in a manner that was comparable to what happened at the national level. And then the other thing we look at is hospital mortality, which is the proportion of patients that get admitted after out-of-hospital cardiac arrest that survived hospital discharge. And although we saw a slight increase, that is relatively stable. So overall, if we look at our survival curve compared to when we set out our Save My Heart program in 2014, which is in the blue here, our goal is in the green at 2020. You can see that we, although we have been making significant progress over the past few years, we've sort of fallen back to where we were back in 2014 in the midst of the COVID pandemic. Now, I want to clarify one thing about this data, which is important to understand when you interpret these results. And that's the results we're reporting are based on percentages rather than absolute numbers. And I think it's important to look at the absolute numbers just to get some clarity about what the impact of the pandemic has been. And this graph helps a little bit with understanding that. So if you look at on the left side here, the vertical axis is actually absolute number of patients rather than percentage of patients. And the light gray is EMS treated out of hospital cardiac arrest. The medium gray is number of patients with ROSC. And the black is the number of patients that survived with good neurologic outcome. And what this graph illustrates is that significant increase in EMS treated out of hospital cardiac arrest in 2020 compared to 2019, which was actually a 20% increase. At the same time, the actual number of patients that had return of spontaneous circulation than in 2019, and the actual number of patients that survived with good neurologic outcome in the state of Michigan was relatively the same in 2019 versus 2020, with only a 2% absolute decrease, or 12 less patients. So I think this is something important to understand, is that even though our percentages have decreased year over year, the absolute number of patients that were successfully resuscitated and successfully survived with good outcome is very similar. And what we need to understand is what proportion of this additional increase in out-of-hospital cardiac arrest were patients that could have been salvaged versus ones that weren't. And we'll learn more about that, obviously, as we move on beyond the pandemic. So again, the positive note is that the work that everyone is doing in the state of Michigan to save lives from out-of-hospital cardiac arrest is still working. We saved 537 people based on the CARES registry in 2020. And I just, again, appreciate everybody's work and dedication to make that happen. In summary, from our data, we had a 20% increase in EMS treated out-of-hospital cardiac arrest. Our bystander CPR rate and bystander AED percentages remained relatively stable. We did see a decrease in the percentage of patients that had return of spontaneous circulation and the percent of patients that survived, but the absolute number of patients with return of spontaneous circulation and survival was relatively stable. So moving forward, and what we want to really address at this conference is we hope to be approaching the light at the end of the tunnel as the vaccine gets distributed and we get a high rate of vaccination rate. We approach herd immunity. How will our system of care for out-of-hospital cardiac arrest emerge from this, all the way from looking at how the bystander responds, how EMS functions in what will be the new normal, and then how our dispatch will work and our hospital care will continue to improve. And in addition, since we've reached 2020, we didn't reach our 2020 goals, and I think we have to own that. Some of that obviously is attributable to the pandemic, but as we move forward, I think we need to think about setting a new set of goals for beyond 2020, and ideally these would be specific, measurable, attainable, realistic, and time-based. And with that, I will turn it back over to Jim to see if there's any questions.
Thank you so much, Bob. That was a great overview of kind of where we were and where we're going, how we might want to get there. We do have time for maybe one question if there's a question in the chat. So here's a question from Eric Snyderich. The number of EMS treated cardiac arrests increased by 20%. Is that corrected for agencies that started reporting in 2020? Is the number per capita up 20%? If so, was this attributed to limited access to primary or chronic care during COVID?
Yeah, those are all really good questions. The number of, and I checked this with Terry Shields, as my understanding is the number of EMS systems reporting was the same in 2019 to 2020. So we don't attribute that increase to more EMS systems participating. As I showed you in one of my early slides, the overall death rate in the state of Michigan increased by 18%. So that's similar to the increase in 20% number for EMS treated out of hospital cardiac arrest. I think the etiology, we need to dig a little bit deeper regarding how much of that increased incidence is due to COVID itself, which some of it is, but I don't think all of it is. I think a component of it is related to people deferring medical care, either voluntarily because they're afraid to seek medical care, or even involuntarily, especially in April when many of the health systems shut down their elective healthcare system. I know at our own institution, there was many deferred surgeries, for example, that may have been related to this, but we have also, heard stories about people with things like chest pain that, come in, later on because they're afraid to come in and may deteriorate, MI may be deteriorating into cardiac arrest rather than getting to the ED with a STEMI and getting to the cath lab and having that pathology resolved. So we don't know the answers to that. I think we're going to try to dig deeper into that. And I think as we move into the years to come and see what kind of what the incidence looks like beyond COVID, that'll help us understand that.
Terrific. I have to end it there, but that's a great discussion and a great springboard to the rest of the conference. Really appreciate your time. So I want to move on to the next session. We are all here because we are passionate about improving cardiac arrest survival. Behind these survival rates are real people with real lives. Like Dr. Newmar said, there's 537 real lives that were saved this past year. And we feel it's critical to our mission to never lose sight of the true reason why we're doing this work. I would like to introduce Dr. Tony Sue, who will introduce our survivor talk today. Tony, you can go ahead and I'll stop sharing and you can share, or you can come on.
Hello, everyone. Welcome to the survivor section. Over the past 6 years, as we've had conferences, we've highlighted the story of several survivors. Today is a really special one. This is one that really hits home, literally. Mr. Yonkers, Roger, we'll call him, is a dispatcher at a 911 call center of Pride Care Ambulance. He unfortunately suffered cardiac arrest, and his team had to gather around him and save his life. So we had to save one of our own. So I'd like to bring on Roger Yonkers, who will be sitting next to Jesse Brittingham, the fellow dispatcher that also recognized and helped save his life. We also have a few other members of the team, including Tyler Webb, Tyler Dunfield, and perhaps Gary Williams. Some of them have been working 24-hour shifts up until today, and so they are actively continuing to practice. Welcome, Roger.
Hi. Can you hear me okay?
Tell us about, yeah, we can hear you just fine. Tell us about how things have been.
Pretty much been back to normal. Nothing has really changed a whole lot.
What has occurred since the arrest of, since your arrest?
Well, in the hospital, they decided to place an ICD that has to be monitored, but other than that, I'm back to work and everything seems fine.
Can you remember what happened just before and since then, when that day of your arrest?
I remember walking back into the dispatch room and I just got kind of an odd head rush. I sat down at my desk and I remember kind of resting my head on my hand. And that's the last thing I remember. One of the other dispatchers said I actually took a call and then he saw me slump over in my chair and that's when he got me down on the floor.
Sounds like a very sudden cardiac arrest. Yes. And of course, Jesse, I see you sitting to his left. I assume that he wasn't sleeping on the job. Is that kind of what you noticed?
I was actually just coming in for my shift. I'm an EMT, so I was just coming in for my shift on the road. I don't work in the dispatch center.
Okay.
I had come in and I heard his partner yelling for help. So I went to the window and I saw him like holding Roger up. And so I went into the dispatch center and I tried to get his attention and I couldn't get him to respond or anything. And then that's when Tyler came running in. And then by that time, Tyler had gotten the cardiac monitor in the bag and we had gotten all that going. And then Gary and Tyler Webb got there.
So how did your experience with COVID-19 surrounding Roger's arrest change your thoughts about providing the care that you did?
It didn't. I just sprang into action and did my job.
Great. Do you have anybody else on your team around, perhaps sitting next to you guys?
We have Tyler Dunfield behind us.
Yeah, Tyler's on and I see Gary's on also.
All right. Well, Tyler or Gary, we'd like to have your input as to what you saw and what you thought about the teamwork. You're on mute, Gary. I'm sorry.
There, now can you hear me?
We're good.
Okay, the teamwork was excellent. Everybody worked like a rock star. You know, Roger's arrest, we chalked it up as a big win. Not just because he was, you know, one of our own, but just overall, it was a great experience and a good learning experience for all of us. We got called, we were actually headed into our headquarters for a little bit of minor repair on our vehicle. And they upgraded us to priority 1, not really sure why. In my head, I was thinking maybe Roger's blood sugar had went low. And when we got there, we brought all of our equipment in. Tyler and Jesse were there. And Roger was breathing at that time, not very well. We checked the blood sugar. That was fine. At that point, Roger kind of started agonal breathing. I checked the pulse and recognized that he was definitely in pulseless and in cardiac arrest. Tyler Webb, I advised him to start CPR. I jumped on the other side and started an IV while Tyler Dunfield placed pads. I got the IV started, pads were placed. We found VFib on the monitor. We shocked him 1 time, and within, I don't know, less than a minute, we had a normal sinus rhythm, and his eyes were opening back up. So it was a very quick process.
Now, I think Tyler Webb is actually on the call.
Yes, sir, I am.
Go ahead.
Yeah, I mean, I believe that the teamwork throughout the process worked very well. We all filled the roles that we needed to, from getting pads onto our patient, getting them onto Roger, having an airway secured, continuing compressions, delivering a shock when realizing that we were in VFib. It was a pretty amazing experience to see Roger's eyes open up too after 1 shock and continuing compressions. He came around to the point where he was actually able to respond with us and talked with us the entire time to the hospital. Became A&O ×4 during the process.
Well, Roger, this is fantastic. We didn't know the whole story. I hope that your recovery seems to have been complete. I heard from Robert Lorberg that you are back at work. Is that right? And how has your immediate family and closer friends adjusted to the changes brought on by your cardiac arrest?
Yeah, I'm kind of a glutton for punishment, I guess you could say. I was back to work 9 days post-arrest. I was limited from road duty due to not wanting me to pick up more than like 15 pounds, I believe. Really, I mean, the only person I think has really had a hard time with this is my sister, because she lives in Florida. So she hasn't been able to physically see me. So I talked to her a lot about everything that's going on. And the one thing that Tyler was saying that I found kind of odd is, well, I still had my eyes closed. I guess I kind of started coming to, and I just kind of laid there and thought, why does it feel like my chest is moving? So the last couple of compressions he did, I could actually feel them. And then I opened my eyes, and that's when Gary told him that my eyes were open and to quit doing compressions, which I appreciated.
That is pretty amazing. Well, you are a dispatcher. How do you think that the experience of, having been in suffering cardiac arrest has changed your perspective as a dispatcher? Has it in any way?
I mean, not a lot, I guess. When we get cardiac arrest cases, I can kind of relate to them a little more now, having been through it myself. That
Do you
would be the
feel
biggest-
that? Do you feel that perhaps, you know, there's a potential for every 911 emergency call to possibly be a sudden cardiac arrest until proven otherwise?
Oh, absolutely. We had one the other day. It came in as a fall, and that the person was a little altered, and by the time we got there, it had turned into a cardiac arrest.
Fantastic, fantastic. I hope that case went well. I am missing Tyler Dunfield. Is she around?
Yes, she is. You,
Yeah, I'm right here. Hi.
Come closer, come closer. I think
Okay, how's that?
the background. You can go ahead and tell us what you saw.
Ooh. Okay, is that better?
Still a lot of reverb.
okay, she's gonna try to come up by my computer a minute, because she was behind me at hers, and it just wasn't working very well. There she
Not a
is.
problem.
Okay, so yeah, one of our dispatchers came running out and said, hey, we need help. It's Roger. So I go running in there because we were all really kind of surprised of like what was going on. Saw Roger on the floor. He was breathing, like Gary said, not well. And so I knew that we needed an airway. So I went out and I got the our airway bag and our cardiac monitor back with that and got an NPA. Jesse was still at the head of Roger. And then Gary and Tyler showed up, and then we all just really worked together.
That's great. I like the teamwork and everybody kind of having a role, and you know, Tyler Webb doing compressions. You know, I don't know how many of our dispatch centers actually have immediate access to AEDs. Seems like you know, you put the pads on, you had your gear with you, but I'm wondering if, you know, if every dispatch center actually has an AED. I would imagine anything that is as high stress level as being a dispatcher should have access to one, just in case. What about the debrief that occurred or is potentially still occurring? Anybody can talk. Gary, how was the debrief afterwards? Or
Well, the debriefing, I did attend the debriefing, but I attended our dispatchers were having kind of all of the other dispatchers were having more of an issue with it than the crew that actually worked on Roger. A lot of us have worked together for quite a while, and we know our job. We know how to do our job, and we're very good at it because we've been doing it so long. Some of the other dispatchers were having a real problem with it, and when they mentioned the debriefing, you know, I kind of stated, well, I'm perfectly fine with this. I consider this a win. You know, this was a great experience. We got Roger back, and everything was fine. But I did attend the debriefing for the other dispatchers that were kind of having a problem, and kind of projected that attitude towards this situation, that look, this was a great experience. I understand that what you saw and what happened in there and what you saw and you had to take part in, you know, was kind of a bad thing, but it turned out very well. And I believe the debriefing went well. Everybody feels a little bit better about it because of being able to talk about it with everyone. So, you know, debriefings are a good thing, but I think everybody is doing a lot better with it now.
it feels like it was a close call. I imagine there are many people who, even medics who see cardiac and respond to cardiac arrests, feel like it was probably a very close call for some of their friends. Roger, if you're still on, can you tell us about your activity level? Are you kind of completely recovered physically? Or did the cardiologist find out what happened? Feel free to say no if you don't want to talk about personal health
yeah,
stuff.
that's fine. They stated it's a hereditary I know I'm missing part of it. Cardiomyopathy. hypertrophic cardiomyopathy. That's what they called it.
Mm.
So it's a genetic thing, they said. So I went through some genetic testing to make, I don't totally understand it, make sure I wasn't an active carrier of the gene. And then my sister had to go through the same thing to make sure she wasn't a carrier, which neither one of us were. So they said we should be in the clear. But they said now that I have the extra stent, because I now have 3 stents in the ICD, they said I should be good. I did return to a couple weeks. While I was in the hospital due to the cardiac arrest, I also ended up having a gallbladder attack. So they kept me for a few more days for that. So 2 weeks ago, I just had my gallbladder out. So I am back on restricted duty for a few more weeks, but I'm still able to dispatch. So I just can't be out on an ambulance right now.
Sounds like you're even more efficient than you used to be. That's awesome. I wonder if, it makes you think about even faster responses, perhaps something called a no-go protocol. This is something that Save My Heart and many of our dispatch experts have been advocating, something to think about. Do you see any other changes at the dispatch center that you would like to see where you are?
None that I can really think of. Everything, the protocols we have in place, I believe, are pretty efficient.
That's great. That's great to hear. When I think of interacting with all the survivors that I've had, family members seem to be the most shook up. Friends and coworkers are probably the next level. One of the things that we think about with survivorhood, as we hopefully become even more successful than we have been, is their ability to recover, how they can also feel like they've perhaps assuaged some of their guilt of not doing everything perfectly, a little bit of introspection. Does any of your colleagues there sitting next to you have any thoughts about, yes, this was a true success, Gary, you're absolutely right. Are there any other thoughts about what we can do as a state to move forward? Because that's what this conference is going to be about.
I think that, we do have AEDs in a lot of places. I believe AEDs are one of the key factors in cardiac arrest survival. Early CPR and early placement of the AED. That's the number one thing I believe is going to help us save more lives. So places, that we don't have them, we don't have AEDs in our dispatch center. We have cardiac monitors in our ambulances that'll be in the bay. But an AED in the dispatch center, I think, is a very good idea. The more AEDs we can get placed, I think the more lives we'll save.
And Mrs. Dunfield, what do you think?
I agree with what Gary said. More AEDs and more bystander CPR and people knowing how to do CPR. And the earlier you can activate the 911 system.
Yeah, so the 911 system
because the
efficiency. Sorry, go ahead, please.
The doctors at the hospital told me if I wasn't at during this, I probably would have not have made it. So
something that we're definitely focusing in the community response is making sure that people like Tyler and Gary, the level of training, perhaps at least just starting compressions, is what we want in our community. People that are comfortable with providing compressions, even in a time of COVID, starting early on as much as possible. But yes, that definitely seems to be a demand issue. We need more AEDs. We need more public accessible AEDs, not just locked up in school afterwards, but after the school events or at other large gatherings, picnics, concerts, stuff like that. I would direct you to the Save My Heart website, which is just behind me, but actually it's something that you can go onto your web simply click on the link that Terry Shields has put in the chat, savemyheart.org. Join us in the community response group. We're always looking for people who are willing to try to help document where the AEDs are. We're working on a database that can hopefully be searchable, and during these events, you can hopefully eventually pull out your phone and find the AED if the dispatcher says, there's one down the block, run and go get it and save someone's life like Roger's. We are working on that. Not everybody will survive, but we've got to try, as you said. Many times when it's successful, we can put our needed public service and friends and family back to their regular daily life. Before I wrap up here, I'd like to ask if you have any other words of wisdom, Roger, having survived this, to let us know what you think.
Nothing I can really think of now.
Well, I want to thank you so very much. Everybody, please take a look at the chat. There are a lot of websites that are being shared regarding how to save your friends and family's life, and you can refer your friends and family to them, to these websites as well. Thank you so much for the time. I want to thank the medics that are sitting and standing next to you and in their cars, joining us even after a 24-hour shift. Thank you, everyone. And I'll give it back to Dr. Pribble at this time.
Well, thank you for sharing your story and how quick action can truly make a difference. Really know it's really brave of you guys to come on and tell us your story. They really mentioned some really key aspects of increasing cardiac arrest survival, AEDs, early CPR, telephone CPR. We're going to be really focusing on a lot of those during, we're going to talk about those things throughout the course of this conference, and really want to, yeah, it's a real good kind of point to make going forward. I also want to bring up a point that I think Dr. Newmar said before in the past. You know, Mr. Yonker was said he was kind of lucky to be where he was when this happened, and we as a group going forward, we want to make it so people don't have to be lucky to survive cardiac arrest, right? So really focus on trying to improve these things that we talk about today. So really appreciate you guys sharing your survivor story. I want to move on to the next section here. And before I do that, I want to, let me see here, question 2. And before I move on to the next section, I want to just open up another poll question, poll question number 2. Let me see, hopefully this will work for everyone. Let me see, poll question number 2. Launch the poll. Which of the following issues do you think is the most important to improve out-of-hospital cardiac arrest survival? Increasing bystander CPR rates, increasing the number of 911 dispatch centers that provide telephone CPR instruction, increasing availability of public AEDs, increasing CPR training sites. Okay, we'll end the poll and show people the results. Okay, looks like people, majority say increasing bystander CPR rates. All those are important, but interesting to get the take on from the group here. So we'll stop sharing that. All right, now I'd like to move on to the first of our 2 main sessions for today's conference. The first few presentations will focus on community response, including 911 dispatch and telephone CPR. Please remember to ask questions through the chat function and use these sessions as a framework for the later discussion sessions that we have set up. Move on to our next. And I want to bring back on Dr. Newmar. He gave us a great overview of the data, where we are, where we want to go, kind of how the blips of COVID have come about. But now he's going to take a little deeper dive into the Michigan Cares data regarding community response outcomes, so we can have that as a backdrop for the next few presentations. I'll stop sharing my slides, Dr. Newmar, and you can take over.
All right. Well, thank you. Can everybody hear me okay?
You sound great.
Okay. And my slides are showing all right?
Your slides are showing and your video is up.
Okay, wonderful. Thank you. All right, so we're going to do a little bit more granular look at some of our community response data statewide and try to use this to help guide our discussions moving forward of how we're going to move the needle on these particular process measures within the system of care. As I mentioned before, our bystander CPR rate in 2020 came in at 40.7%, which was down a little bit from the year before, but nowhere near what many of us expected with the potential concerns of bystanders delivering CPR and the potential risk of COVID transmission. I think part of the explanation for that is that during the peaks of the COVID pandemic, the proportions of cardiac arrests that occurred in a public place also declined. So for cardiac arrests that occurred at home, especially, typically the people living in that home are the ones that do the bystander CPR and probably are less reluctant to do CPR based on COVID transmission, since it's someone they've probably been living with already. So that's one of the explanations that has been put forward why we think the bystander CPR rate overall didn't have a significant decline. Although if you do look at the numbers for bystander CPR in the public setting, which is a small proportion of the total cardiac arrest, there is some signal there that might have gone down a little bit. Similarly, with the bystander AED application rate, we had been seeing significant growth with that plateaued over the past year. But the decline that we saw was less than what was seen nationally, which again is encouraging with our rate currently at 9.7%, which is pretty strong. I mentioned before the issue of arrest in a public location, and a lot of that changes the demographics of the people that would be performing bystander CPR. And as you can see, as we suspected during these peaks, especially in April and then in December, these are sort of the peak waves in Michigan when we had the highest incidence of new COVID infections. You can see the proportion of patients that had a cardiac arrest in a public location decreased significantly in those time periods. With, again, people being less active, being less present in public places, that makes sense. But that also sort of contributes to the differences potentially in the bystander response. Similarly, although the bystander AED is a little bit harder to interpret because actually the proportion was a little bit higher in April, but much lower in December. I think this is just a symptom that the overall numbers are relatively small. So I think it's difficult to interpret the month-to-month data on the bystander AED rate. And then this is our overall bystander CPR rate excluding nursing homes. So CARES, the initial data I reported with a 40.7% rate is overall bystander CPR that does include nursing home patients. This is the monthly data for bystander CPR that actually excludes nursing home patients. So this would be either at a residence or a private setting. And again, the numbers look pretty surprisingly pretty stable in terms of people's willingness to do bystander CPR. And again, I do think that this speaks to the fact that the great proportion of the arrests were not in a public setting, which would be probably where people have the greatest reluctancy to do bystander CPR on someone that they may not know or have seen before. And then finally, this is what I really want to emphasize, is the variability that we see in bystander CPR rates across the state. So again, if you look at our overall bystander CPR rate with Excluding nursing homes, that comes in at about 36%. So about a third of patients that have an out-of-hospital cardiac arrest outside a nursing home are getting bystander CPR. But the variability is tremendous. So this graph is based on EMS transporting agency because that's how the data is reported. And it only includes agencies that report 50 or more non-traumatic cardiac arrests in 2020. And what we see is that bystander CPR rate, although our average is 36%, we have numbers as low as less than 5%, and then all the way up to 70%. And I think this is something that we really should focus on as a tremendous learning opportunity in terms of trying to, if we can, because I think if we can understand the underlying reasons for these disparities between different parts of Michigan, we can learn perhaps best practices and ways to optimize our bystander CPR rate, because these rates we're seeing, anything above 50% is really tremendous. And these are rates that were part of our 2020 goal for the entire state. Certainly there are some regions of Michigan where these bystander CPR rates can be achieved, and it demonstrates the feasibility of that. And if we can learn from those sites, things that might be can be transported to other parts of Michigan where the bystander CPR rates are much lower, we might be able to improve our overall average and overall outcomes, especially in light of the results of the most recent, the survey we just did, which the people participating in this conference feel that increasing our bystander CPR rates is the highest priority. I would add to that, we might want to think about reducing the disparity of bystander CPR rates by learning from areas that have had the greatest success. And again, as we talk about this with our subsequent speakers, I want everyone to think about what our goals might be for beyond 2020 in terms of bystander response. And with that, I will give it back to Dr. Purble.
Thank you so much, Bob. That is a great deep dive into the community response outcomes from CARES. I know you talked about the variability in bystander CPR being maybe an opportunity, and that really needs some research. But one question to you, in your gestalt, what do you think be the biggest explainer of that variability, if any?
Yeah, I don't know the answer to that. I think that that's something that obviously when we look at all this data, we're blinded to the transporting agencies. So I think one of the things that a challenge moving forward might be to really understand what's happening in the different communities and how we can potentially impact that. Probably the best way to get at the answers is really going out into the community and talking to people in the various communities where bystander CPR rates are high and low, and learning what the barriers are in terms of whether it's a barrier of training or knowledge or barrier of willingness to act, and trying to get a much better understanding really at the local level, what the challenges are.
Yeah, that's great. So maybe identifying, these lower and higher rate groups and doing really focus groups, kind of understanding what their issues are at the ground level. That's great. Let me see. I think what we'll do is we'll move on to the next speaker. What I'm going to do is advance my slide here if I can. All right. So let me see here. Is that the right one? So what I'd like to do now is go on to our next speaker. And our next speaker is Kira Landon. Miss Landon is the community CPR manager for the American Heart Association. She will help us understand bystander CPR training in Michigan and also in the Midwest, and also try to identify some of the barriers and opportunities that might be available to us now that we've gone through COVID and had that happen to us. So Ms. Landon, what I'll do is I will stop sharing my screen and you can go ahead and share your screen and your slides.
Wonderful. Thank you so much. Good morning, everybody. Happy to be here. Let me set up my screen. This top bar always throws me off.
Take your time, you're great.
If you go to transitions and start,
The problem is I can't access that top bar because the Zoom bar is kind of blocking it. This happened to me last time.
over to the right just a little.
I can't see it because the Zoom bar is blocking it.
The very
Oh,
bottom
boy.
next to the Zoom.
Oh, wait. Okay. I figured it out, guys. All right. Here we go. Thank you so much for your patience. I really appreciate it.
No worries.
Let me move this over. All right. So in terms of bystander CPR in Michigan, especially the last year, in terms of training numbers, before COVID, in community CPR, we trained about 358,500 individuals in Michigan just in community CPR. Along with our certification resources. So there's the community CPR world and there's the certification world in the AHA. Combined, we trained a total of approximately 765,000. We definitely saw a decline in those numbers due to COVID. In terms of in community CPR, we trained 225,000 in community CPR. With certification, the number dropped down to 590,000 this year. You know, how have we been doing these trainings? Myself, I am the Midwest team, so everything has been virtual. Luckily, with our resources, our CPR Anytime Adult and Child Kit, they're self-facilitated resources. So we've been utilizing those to work with community partners and those CPR champions that are willing to do trainings via Zoom, via webinar. And we just ensure that both parties have those resources in order to practice those psychomotor skills. We've also been very intentional in terms of where we're providing programming. We are looking at underserved, marginalized communities, communities of color at the end of the day. So truly, this is a conversation of, you know, of barriers and opportunities. I'll be quite frank, the barriers in this is systemic racism. Wherever in the country there are minority groups, there's going to be a less chance of survival for out-of-hospital cardiac arrest. The opportunities we have is if we have the data, if we know exactly where these groups are living, and if we have the data in terms of where these mortalities are happening, then we can do targeted training and go exactly where we need to be to provide that training. So I'll cover that a little bit more in this presentation. So I wanted to give an overview of the AHA guideline updates. There were quite a few new recommendations. These are just a couple that I wanted to highlight. You know, we came out with these guidelines in October, so in the middle of the pandemic. I'll have a link to the full guidelines if you're interested in that. But some highlights, we've provided 2 new opioid emergency protocols, emphasizing the use of lay rescuers using Narcan and providing CPR. Definitely emphasizing telephone CPR, mobile phone technology in order to improve bystander CPR rates. And then here we are, encouraging bystander training tailored to socioeconomic, racial, and ethnic populations with lower rates of bystander CPR, while also addressing gender-related barriers to improve bystander CPR rates for women. and then along with new pediatric CPR recommendations. So here's what we know in terms of improving survival of cardiac arrest. We know that we need to increase CPR training in lower socioeconomic underserved areas, decreasing time to EMS activation, telephone CPR, and improving access to bystander AEDs. Again, we can't ignore that there are disparities in death rates identified by gender, race, and socioeconomic factors. So we know there are health risks associated with cardiac arrest, but we also can't ignore that there are socioeconomic risks that are correlated to these increase of death through cardiac arrest. And that's having low family income, being of minority race, being in a single family home, and low education level, right? So the AHA is aiming to improve cardiovascular health while including addressing both those health risk factors and socioeconomic factors, right? So we're also identifying the gender disparity. Women are less likely to receive CPR. Only 39% of women receive CPR in comparison to 45% of men. Men's odds of survival are 23% higher than women's. Now, a lot of this has to do with the female anatomy, also some just, either myths about, will I get sued because I'm touching them inappropriately, or again, the female anatomy. And studies have shown that people are less likely to practice on a mannequin with the female anatomy than with a mannequin that does not have breasts. So, what are we trying to do? We're trying to, promote female representation in training videos, reminding people that the Good Samaritan law is there to protect you, and reminding people that hands-only CPR is performed essentially the same way on a man as it is on a woman, right? And so also, again, with targeted training, this does provide an opportunity to say, we need to address the men in the community and the men in our lives, because women are often the first to take action, very willing to help and perform bystander CPR. And so the question in turn is, why are men so hesitant? And having those conversations and truly digging deep there and providing awareness around this. So a little bit about the race and socioeconomic disparities. So we know across the board, across the Midwest, that minority communities are less likely to survive cardiac arrest, less likely to receive bystander CPR, and less likely to receive this education, right? So we are trying our best, again, to identify those communities and provide them with the resources that they need. Again, it's drastically different within a state. It's truly dependent on where you live and what the resources are in that area, right? And again, we find that communities of color are often affected by this, and in turn are less likely to survive. So in Michigan, thanks to the Department of Emergency Medicine and Integrated Bioscience Center at Wayne State University, they found that during COVID-19, out-of-hospital cardiac arrest increased by 62% in Detroit. We know that the demographics in Detroit are about 97% African American. Another study by the Michigan State University showed a 60% increase in out-of-hospital cardiac arrest during the first few months, with a 42% increase in deaths over the same period the previous year, showing that a disproportionate percentage of those cases were among Black community members. So how do we address these disparities, and how do we improve, right? Again, community involvement is key. Dr. Newmar mentioned, talking to these communities and, getting it from the source. What do they need? What are they missing? Yes, that is a wonderful, great step. But also we need to take a look around and see who is helping us make these decisions. Looking at the people that are involved in Save My Heart, is there diversity in this space? Are we including those community leaders to help us make those decisions, right? It's truly a matter of having them have a seat at the table. That's how we increase relationships within the community. It's truly a matter of relationship building there. And again, targeted trainings for minority communities when data is available. So for example, in Muskegon County, Michigan, we partnered with the Public Health Department and their child death review team. They had data to the neighborhood of where child death was occurring, infant early child death, so before the age of 1 in Muskegon Heights. Their rate of infant mortality increased over 100% in the past from the years of in the past 5 years or so, and I can provide that article for backup. But when I learned that statistic and I reached out to the child death review team, they said, yes, this is definitely a prevalent issue in this area. The area is predominantly African American. We had that data available. We approached the Gerber Foundation to help us secure resources, CPR training resources, to provide infant CPR training in that area. And that's just to highlight the importance of having that data available. We know it's not always there, but having that data and showing it to people that can connect the dots and help us make that training happen is truly key. With that group as well, we identified the DAD movement there. They are part of the Public Health Department. These are community members, leaders who are hosting conversations about what it means to be a father in the African American community. And they are leading those trainings, those infant CPR trainings. So that example really just shows how specific we were and where we were going to provide this training and exactly who was going to lead that conversation and lead those trainings, right? So it's a matter of customizing CPR programming, training to match community strengths, weaknesses, barriers, and opportunities. So some questions to think about, who are key community leaders in your communities that can help spread awareness and contribute to the conversation? Who can we bring to the table? How do we engage them in the conversation? What pieces are we missing, and can they help us figure out those barriers as well? And that's all I have for today. Thank you so much.
So that was terrific, Kara. Thanks so much for that presentation. We can now open it up. We have a couple minutes for questions. I think, I'll start off. You talk about the need to be inclusive and try to, reach out to the diverse, increase our diversity and reach out to the minority populations. And you talked about identifying those leaders. Can you kind of give one example of the Muskegon Heights? How do you do that for other areas if we find geographic areas that are kind of lower in rates and
Sure.
maybe we don't have that connection? How do you develop those connections? How do you take that first step?
So truly, I'll speak very candid on how I approach, connecting with those leaders. So public health departments often have many new parenting collaboratives, health education programming, and it's often geared towards underserved communities. So connecting with those education coordinators or connecting with the leaders that are providing that programming often involves directly talking to those community members. So it's truly connecting the dots. It's truly making phone calls and saying, hey, I'd love to learn more about, your Great Start to Quality program and who's leading that, or are there any community-led initiatives like a DAD movement or a Fathers Matter program, things like that. I think is a great first step. I think this group is pretty connected in terms of the public health world. So I think just taking a step further and maybe thinking out of the box in terms of, who have I not thought to connect with, or maybe just reach out to, I would say.
That's great. That's great insight. And thanks so much for your experience. Jennifer Fowler's on and monitoring our Q&A session. Any other questions from your perspective, Jennifer, that are to be asked of Ms. Landon?
Oh, great presentation, Kira. Does the AHA have any planned community trainings in Michigan this year?
So we are providing infant CPR training throughout Detroit with the help of our Detroit EMS partners and the public health department there, and the Great Start to Quality program. So that infant CPR training is ongoing until October, and we're focused on providing that infant CPR training to home care providers and new parents through new parenting collaboratives. The Muskegon Heights infant CPR trainings are also continuing on until October. In terms of more mass trainings held by the AHA itself, we are still committed to the virtual experience. We are not encouraging anyone to gather, but that doesn't mean that we're not continuing CPR programming in schools, providing teachers with those resources, along with hospitals and other community organizations with the capabilities of virtual CPR training. So it's definitely ongoing.
Okay, thank you.
That's great. I think we have to stop it there to move on to the next section. But Kira, thanks so much for your time to come here and give us your expertise and your perspective. I think is a very important perspective and something that we need to kind of use moving forward and save my heart. Thank you so much. So what I'd like to do is move on to our next speaker. And we have the pleasure of our next speaker being Dr. Cindy Sue. Dr. Sue is an assistant professor of emergency medicine and surgery at the University of Michigan. She has done some amazing work looking at the safety implications of performing CPR during the COVID-19 pandemic. And she's here to present her findings and her perspective. Cindy, you can take it from here. I'll stop my screen and you can take over.
Great. Thank you, Jim. Can you guys hear me okay?
Hear you great.
All right, I'm going to share my slides. All right. Is the slide showing up okay for you guys?
Looks great.
All right, excellent. Well, thank you, everybody. It's an honor to be here today to talk to a great audience. I'm going to talk to you about some of our work focusing on whether or not it's safe to perform CPR during the COVID-19 pandemic. These are my disclosures. So really the question on hand is it safe to perform CPR during a pandemic? And more specifically, does CPR generate aerosols that can transmit respiratory pathogens like the SARS-CoV-2 virus? And this is particularly important question for the lay rescuers who are most likely not going to have PPE readily available when they are confronted with a cardiac arrest victims outside a hospital. And more importantly, our decisions to guide the level of PPE should really be based on hopefully evidence on this topic. And so what have the resuscitation committees recommended so far? So last year, LCOR conducted a systematic review on this topic, and they basically came to the conclusion that it was uncertain whether or not chest compressions or defibrillation can cause generation or transmission of COVID-19 to rescuers based on the lack of concrete evidence. So what they recommended or suggested in the COVID-19 consensus on science and treatment guidelines was for the lay rescuers to consider compressions and public access defibrillation, and then for the healthcare providers to consider defibrillation before donning PPE for aerosol generating procedures in situations where providers assess the benefits may exceed the risk. And both of these were good practice statements. The AHA similarly in their interim guidance for COVID-19 last year stated that for chest compressions for adults, the lay rescuers should perform at least hands-only CPR after recognition of a cardiac arrest event, because if they are, most of them are likely due to the social distancing and shutdown, most likely were household members who have already been exposed to the patient at home. They further stated that a face mask or covering of mouth or nose for the rescuers and or the patient may reduce the risk of transmission to the bystander. With regards to the public access defibrillation, the AHA stated that the lay rescuers should use an automated AED if available to assess and treat the patients for out-of-hospital cardiac arrest. So what we wanted to do was to use our large animal model to try to get at this question of whether or not CPR could in fact generate aerosol to really better inform our decisions. And here I've included a QR code that will lead you to our study published in Resuscitation last year. So just to tell you what we did, we used our established cardiac arrest model to really study the aerosol generation during CPR. And so the schematic on the left highlights the setup in our lab. So we used Lucas 2 as our mechanical CPR device. The swines, we used 3 swines. They were intubated for instrumentation and then extubated while properly sedated. And we connected essentially via a nose cone to a device, aerosol analyzer called TSI, optical particle sizer. And this device actually enabled us to measure particles with diameters from 0.3 to 10 microns. And we were able to essentially achieve, also maintain hemodynamic monitoring as we usually do for the SWI model. Why do we want to focus on the 10 micron particles? Based on really decades of studies on respiratory particle transmission and pathogens, disease transmissions, we know that those with diameters less than 10 micron have the highest likelihood to penetrate past the glottis, as demonstrated by the schematic on the left. And furthermore, those are less than 5 microns in size have the highest potential to penetrate down to the alveolar space to potentially cause infections. The ones that are bigger than 20 microns in size tend to have the more ballistic trajectory, where they essentially will linger around in the air rather than entering your airway. And those the particles that are 10 to 20 could either remain suspended or settled on surfaces. So this is our experimental timeline. So we wanted to simulate witness out-of-hospital cardiac arrest with bystander initiated CPR. So what we did was we induced VFib, ventricular fibrillation cardiac arrest, by injection of potassium chloride. And we left the animal untreated in VFib for 4 minutes. And then we started mechanical CPR. And then we interspersed with 200 joules of defibrillation every 2 minutes of CPR. And we repeated that cycle 10 times. If you look at the bottom flow sheet, the timeline, we actually further divided the time intervals into 45-second intervals in order to really differentiate it, the aerosol measurement. So we measure 45 seconds of no flow, and then also 45 seconds of pre-defibrillation chest compression, and then 45 seconds of post-defibrillation chest compressions. And we do this 10 times per animal. And what we found was actually quite interesting and perhaps surprising. So I'm just going to orient you on in terms of the graph on the left here. On the x-axis, essentially was the aerosol diameter in microns from 0.3 to 10 microns. And then on the y-axis was the mean aerosol count during the different time intervals. The white bar represented baseline before the experiment started. The light gray bar represented no flow or during VFib cardiac arrest untreated. The darker gray bar represented pre-defibrillation chest compressions, and then the shaded bar represented post-defibrillation chest compressions period. And so what we found was that there was in fact no significant difference between total aerosols generated during pre-defib chest compressions compared to no flow. So basically that means that comparing a patient who was just laying there in cardiac arrest versus chest compression initiation, there's actually no difference in aerosol generation. In contrast, however, the post-defib chest compression generated significantly more aerosols than pre-defib chest compressions. As you can see, particularly in the size range from 0.7 micron in diameter or greater. So how does that compare to what happens in humans? So what we did was we actually recruited 4 healthy humans, which is 4 of us in the lab, and the 4 of us actually coughed into the clean nose cone. And we quantify the size and the quantity of the aerosols generated from 2 coughs from each of the 4 of us. And what we found was that compared to post-defib chest compressions in the swine, human coughs, healthy human coughs, generated significantly more smaller particles of the 0.3 to 0.46 diameter range than in the swine post-defib chest compressions. Conversely, the swine post-defib chest compressions generated significantly more of these higher or the larger particles of 1 micron or larger compared to human coughs. And this is further illustrated here by the individual contour diagram. So on the left side here are each of these 3 swine, and on the x-axis, essentially from each of the, essentially one of these graphs represented 1 cycle of the resuscitations from time 0 seconds to 120 seconds, and with the dotted line in the middle representing each of the defib. And so you can see in the swine, there's a tremendous release of aerosol from really the great range of sizes, but particularly in the larger end. Whereas in the humans on the right here, each of the coughs generated many more of these smaller particles compared to the swine. So in conclusions, we found that in our swine model, chest compressions alone did not cause significant aerosol generation. An increase in aerosol generation was detected during chest compression immediately following defibrillation. And then the mechanism and clinical significance of our observations require further investigation. There's definitely limitations to our study. First was the small sample size. We used 3 swine and 4 humans, although we repeated multiple sampling from each of the animals, and they were consistent across. There was definitely airway anatomy differences between swine and humans. We only measured diameter of 10 microns or smaller of aerosols, as I mentioned. We also didn't, we couldn't really detect or measure differences of the effects of temperature, humidity, airflow, and ventilation on aerosol spread during CPR. And finally, the correlations between aerosol quantity during CPR and bioinfectivity remains unclear. So what's next for us? We're hopefully can get this study funded where we want to look at mitigating strategies really using our swine model. And so what we're going to try to do is actually put on different types of masks on the over the pig swine, that's the snout, comparing N95 versus surgical mask and cloth covering mask, and then essentially perform a similar experiment measuring the aerosol generation during the different applications of mask. And simultaneously, we are going to also add on a high-speed camera to then help us measure aerosol cloud dynamics. And this is actually a figure we're going to be continuing to collaborate with our colleagues in mechanical engineering. And this is what they did with the high-speed camera in dental school, actually, where they measure the aerosol cloud dynamics and the half-life and the dispersion of particles during dental drilling with and without suctioning. And with that, I'd like to acknowledge my team. This study would not have been possible with and without a pandemic, but we were able to pull this off during the first wave in April last year, and this tremendous effort by multiple people from Michigan, and especially MCERC. Thank you very much.
Thanks, Cindy. What a tremendous study and very timely, and I think it's going to be really beneficial going forward because identifying that baseline and how this all works is really going to inform how we, recommend, public hands-only CPR and those types of things. So is Terry on as far as the question and answer? We have a few minutes here to ask some questions. I think there's some questions in the chat. Terry, do you have some questions in the chat you want to ask Dr. Sue? And Terry, you're muted.
Hi, Cindy. Thank you so
Hi.
much, Dr. Sue, for a great presentation. What other additional research is needed before we can make recommendations to the public or change guidelines and training?
Yeah, that's a great question. So, I think ultimately is are there studies we can actually perform in humans and how realistic it is? And certainly, the reason why we wanted to perform this follow-up study was the question of whether or not we need to pair, for example, masks with AEDs and what type of mask we should use on the victims, the cardiac arrest victims. And, assuming that hopefully all the rescuers will be already wearing a mask, right? I had the opportunity to be on a radio show a couple of months ago where we talked about the study, and there were callers I called in. And what I realized was that there was a lot of angst, certainly about COVID and potentially doing CPR, bystander CPR in COVID patients. But there's also a lot of fundamental, I think, the lack of knowledge or just understanding of the fact that we don't necessarily need to deliver rescue breaths to cardiac arrest victims. So I think it ultimately comes down to our education, our CPR training to bystanders. I think a lot of, as I mentioned, what Alcor, AHA, and European Society, there's a lot of recommendations that were made with really very little concrete evidence and really based on good sense, right? So we know that based on many studies that masks do work, and hopefully with patients getting, people getting more vaccinated now, that the overall transmission and disease incidence is going to drop. But I think if we can hopefully get to the question of whether or not people need to put on masks. I mean, hopefully the rescuers will put on masks, but also do we need to put on masks on patients? That might be helpful, Joe.
Right. We have a couple additional questions. Dr. Fail would like to know, would you recommend a filter for 10 microns for exhalation port of the mask valve?
That's a good question. So I know that many people are already attaching a viral filter, which would filter the 0.3 microns or larger to the BVM mask. And so that's one way to really minimize the risk. And again, I think for the first responders and the EMS providers, hopefully most if not all of them will have already PPE on. And so I think the difference between lay rescuers and first responders and EMS providers, the level of PPE availability is perhaps a little bit different, particularly when we're talking about now more public cardiac arrest occurrences. So,
right, there's more available PPE now than there was at the beginning of the pandemic too. So.
Right.
And then Dr. Swore would like to know, were these animals intubated?
So they were not, we intubated them for instrumentation, but we extubated them with adequate sedation for the actual experiments to simulate the bystander witness at a hospital cardiac arrest. So.
Okay, great. Well, thank you so much, Dr. Sue.
Thank you
for your presentation. We look forward to your future research.
Thank you.
Good luck in getting that funding. Thank you.
Thanks, Cindy. It looks like Dr. Swore is ready to roll with the next presentation. So if he and April can undo their video, so they're shown on the screen, I can introduce them. So our next presentation will be a combined presentation, and I'd like to introduce Dr. Robert Swore. Dr. Swore is a professor of emergency medicine, director of research and EMS programs at William Beaumont School of Medicine, Oakland University, and April Heinz. April is the 911 and PSAP operations director for NENA, which is the National Emergency Number Association, the 911 Association. They're going to talk about TCPR in Michigan and really help us understand the current framework and how do we all kind of get involved to improve this, because we know it's so important. So with that, I will let you guys take it from there.
Very much, Jim. And it's nice to virtually see everybody on the list. It's great to have a good turnout for this meeting. And it's been heartening to see the number of questions about TCPR in the chat. And we'll do some discussion here, and hopefully we'll spend more time in it in the small groups as we look forward to figuring out how to do this better in Michigan. As all of you have heard, the chain of survival looks critically at having bystanders involved. And getting bystanders involved requires a coach at the time of a cardiac arrest, and we think that's the dispatcher. So telecommunicators' role during CPR is key. They're at the center here. There's one dispatcher that has multiple events of cardiac arrest that they're involved with, whereas a bystander may do this once in their lifetime. Dispatchers do this routinely. So their role during a cardiac arrest is multiple. They dispatch units, get things moving, assist responders, assist the caller with recognizing a cardiac arrest. I've been doing this for a long time, and it still amazes me that I had a cardiac arrest last week in the emergency department with an arterial line in on a cardiac monitor, and we're debating whether that the patient was actually in cardiac arrest at the time, just because some of the nuance of this requires help. What telecommunicator CPR does is it re-inoculates a CPR trained provider who's at this bedside, floor side at the time of a cardiac arrest, thereby enhancing the self-efficacy of the bystander, makes them think that they can do this. And that's key at the time of an incredibly emotional, difficult experience for a bystander, is watching what's usually a family member or loved one have a cardiac arrest in front of them. They need help at that time, and that's the role that the dispatcher plays. And then there's technical aspects of how fast and how deep and recoil, et cetera, but those are all things that the telecommunicator has to do at the time of a cardiac arrest. Telecommunicator CPR works. This is data from the CARES registry in 2017, a study that we did. And you look at the two circles here, you can see that CPR in progress was started in almost 500 cases. And then after telecommunicator CPR, another 973, so almost twice as many people can provide CPR with telecommunicator instructions as opposed to starting CPR before 911 instructions are given. So Ben Bobrow, who is one of the high priests of CPR, telecommunicator CPR nationally, has identified telephone CPR as the secret sauce for improving cardiac arrest survival. And I believe that wholeheartedly. So to try to delve into how do we do this better in Michigan and what's the framework of Michigan, we have to go back to 1909, where the Home Rule Act was enacted in the Michigan Constitution, and it's been amended multiple times, the last in 1919. And what this does is it lays out what the roles of cities, counties, and the state are in providing services and care to the community. And basically what this does is the Home Rule Law, which is similar in about 30 states, delegates to local cities and counties the ability to provide essential services like police protection, garbage, public health, mental health, and not much about 911 services. The 911 Act of 1986 describes how EMS services, how 911 centers provide dispatch. And there's three general ways of doing it as described in this slide. But basically, it tells 911 centers how to send help, but is really silent on the issue of providing pre-arrival instructions, specifically telecommunicator CPR. The EMS Act in 1978, that's been amended in 86 and other times, allows for local medical control authorities, EMS authorities around the state of Michigan, to develop medical protocols to ensure dispatching of a life support agency based on medical need and the capacity of the EMS system. So basically, one, this regulates life support agencies, not public safety answering points. And two, this is relatively silent on the issue of emergency medicine dispatch protocols other than just sending resources, and doesn't really address pre-arrival instructions, specifically telecommunicator CPR. So my non-legal interpretation of this is that medical control authorities don't have legal authority over dispatch. However, we have substantial moral authority in terms of advocating for patient care and influencing dispatch services. And that's probably where the people on the distal portion of this conference have the most ability to provide impact. April helped me a little bit with this, and I drew out just sort of a schematic as to how the structure of dispatch is. And all calls in the state of Michigan go to a public safety answering point, 911 center. They receive the call, either directly transfer that to a PSAP, either answer to a secondary PSAP, either ask a few questions and transfer the call or dispatch resources, and then provide telecommunicator CPR. And so either there's primary PSAPs or secondary PSAPs that provide telecommunicator CPR. But those are the two major ways of doing that in Michigan. In a survey that the state of Michigan 911 Commission provides to the governor and the legislature, there was a survey that in Michigan, there are now 137 public safety answering points in 83 counties. That's actually less, which is better because there's now some consolidation of procedures. And in a survey of that, they identified that there's probably about 1,400 telecommunicators in the state of Michigan. And with a 50% response rate, that's about almost 3,000 telecommunicators in the state of Michigan compared to about 28,000 EMS providers. So there's about 10% as many telecommunicators as there are EMS providers. We did a survey in the state just in preparation for this, emailing 911 centers around the state, and actually did pretty well and captured data from almost 90% of the population of the state, and asked if their 911 center provided emergency medical dispatch. So those are all those things of other than just sending an ambulance, that's giving any sort of pre-arrival instructions, either by protocol or without protocol. And most of the states' 911 centers identify that they provide emergency medical dispatch. A small percentage do not said, no, we don't do it. And then there were another that didn't respond, which leads me to believe that this population does not provide emergency medical dispatch instructions either. So if you look at that, that's probably 1 million or so that don't get EMD and almost 8.3 million that do. Some of that, the majority of that is provided by a primary PSAP. So the people that pick up the phone or the facility that picked up the phone. And almost a third transfer that call to a secondary PSAP who does pre-arrival instructions, including and also dispatches other resources, but would provide telecommunicator assisted CPR. And most of those are public, but again, there's a proportion of the community that provides instruction. So the genesis of this is that most of the states says they provide emergency medical dispatch. Most of it's public agencies, but particularly in the southern part of the state, private agencies that provide secondary public safety services and telecommunicator CPR provide an important role in our state. Some of the barriers are actually most of the PSAPs that don't provide EMD are in southeastern Michigan, which is our small communities around southeastern Michigan, which is somewhat aggravating. It's not an urban, it's not a rural area. We don't have resources issue. Just for comparison, a survey of 911 centers in Ohio said that most of the centers that provide, that are PSAPs in Ohio have a maximum of 3 dispatchers at a time, and half of them only have 1 person at a time. So there's a logistical issue of if you're getting multiple calls, if you're dispatching resources, et cetera, it's kind of hard to provide telecommunicator CPR instructions as well. Another issue is a dispatch agency is not an EMS agency. So dispatchers only know about the cardiac arrest that they know about. So if we're trying to improve the process of providing telecommunicator CPR instructions, there needs to be a link between dispatch and the EMS agency. The dispatch agency can only review cases that they identify as a cardiac arrest. And just like the rest of us, all emergency care providers, they do their bit, hand it off to the next person. And just like paramedics who bring patients to the hospital, emergency physicians that admit patients to the hospital, you can't completely do quality improvement unless you get feedback and evaluate that process vertically through the healthcare system. One way to do that is to use the CARES Dispatch Assisted CPR report. This is an optional module that Terry can turn on for any of you. So if you're not doing any sort of quality improvement of your dispatch CPR process, this is one important means by which to do that. And this is data comparing Michigan to the rest of the country regarding what percentage of people get dispatch assisted CPR after instructions by a dispatcher, how long it takes a dispatcher, how well they recognize CPR, and how long it takes them from the time that the dispatcher gets the call until there's hands on chest. And these are opportunities for improvement and things that this is an important tool that we can use to improve CPR provision, telecommunicator CPR provision, and bystander CPR provision. With that, I'll turn it over to April and how to improve CPR provision, telecommunicator CPR provision in Michigan.
Thank you. So first of all, how are we going to improve? We can mandate, coerce, seduce, collaborate. Collaboration is probably the best option, but what can be done today? So next slide, Dr. Sorry. So what can be done today? Standards. And why standards? The 911 community relies heavily on standards. 911 is a local entity and under local control. Standards ensure consistency between agencies, are industry created and accepted, provide guidance that help PSAPs develop SMART goals, and strengthens an agency's ability to defend their local policies. MENA, the association that I work for, is working with the American Heart Association in creating a telephone CPR standard. That standard should be available later this year. The standard could help in convincing those who are not using these protocols to use them today. Another thing that you can point out when it comes to these PSAPs who are not providing telephone CPR today at minimum or EMD, the state 911 committee has a policy that requires EMD for PSAPs in Michigan. But as Dr. Swore mentioned earlier in his presentation, Michigan is a home rule state. The state 911 committee has no recourse if a PSAP refuses to implement EMD in their area. But local medical control authorities do have a little bit of an option here. They can and maybe should create a protocol for the use of telephone CPR or EMD in their area, and then ensure that that PSAP knows those protocols exist. Liability is a huge concern when it comes to 911. If there are standards or local protocols that PSAPs are refusing to implement, the liability those PSAPs take on goes up significantly in the event of a tragedy. Dr. Swore covered earlier that the vast majority of the state's population is covered by EMD. That sounds great on paper, but that only helps when the caller is in one of those locations. Michigan has a very large tourism industry. We have hundreds of thousands of people that come into our state each and every year. If they are in or having a cardiac emergency and the PSAP they reach out to doesn't provide telephone CPR, then what? Well, you can go around the obstacles. We need to identify the PSAPs that are not using EMD or telephone CPR today. And local medical control authorities have a huge, can play a big role in this. They need to reach out to the PSAP leadership and find out why they're not doing it. Do their best to convince them why they should be doing it. And if they refuse, you can go around them. They answer to somebody. They answer to either municipal councils or boards. They have city managers, elected officials, and even county administrators that they have to answer to. If you can't convince the PSAP, you may be able to convince those that they answer to simply based on liability alone. Next slide. If that doesn't work, maybe it's time for us to look at legislation requiring telephone CPR in Michigan. There are currently 8 different states that have already provided telephone CPR legislation, not provided, but have passed it. And there are another 15 in the United States that require EMD. It isn't necessary for us to reinvent the wheel. Legislation is typically bipartisan in those states that have already introduced or passed. And it doesn't create undue hardships on PSAPs. Next slide. Yep, you got it. For the most part, I'm sorry, back up. For the most part, legislation would be revenue neutral. The cost to deploy telephone CPR is free. Training, on the other hand, has some cost to it. So, but that cost is relatively minimal and isn't cost prohibitive. Michigan has dispatcher training requirements that already are funded through legislation. EMD is already covered under the Michigan dispatcher training requirements. Telephone CPR could be covered as well for those funds, and it would actually cost less than the EMD protocols and training itself. So it's really, ultimately, it would be revenue neutral. Okay, next slide. So training, when we're talking about training, we know that telephone CPR saves lives. We need to encourage PSAPs who are not providing telephone CPR to do so. For PSAPs using EMD or telephone CPR, it's critical that local EMS agencies provide ongoing feedback to the PSAP administrators when calls are not coded appropriately. If they don't, we can't train more effectively or efficiently. There are several online modules available to PSAPs for training. Some of those include EMD Academy programs, the Save My Heart online module, and CPR Lifelines through NHTSA. So quality improvement is also a very important piece. Next slide, Dr. Swore. PSAPs and EMS agency partnerships are crucial. Creating a program, whether internally or more regionally, will help improve the care given to those in need. If responders do not provide that follow-up to the PSAP administration, quality improvement becomes extremely limited. Quality assurance programs are crucial. QA programs provide the necessary review for these types of calls to ensure that the standard of care necessary for callers is provided every time. Dr. Swore already discussed the CARES dispatch module earlier. That is an excellent model for providing quality improvement. There are other integrated approaches throughout the state being used today, and Kent County is a good example of it. They have a dispatch subgroup of their medical control that reviews every cardiac arrest, and dispatch is part of that. So it's important that you're ensuring that your PSAPs are brought into those as well. With that, I think I'm ready to answer any questions.
Terrific. Thanks, April and Bob, for that great talk about, I'm sorry, I have mowers outside my yard. So that great talk. I'm going to bring on Luke Bowen so he can ask some of the questions that are on the chat, and I'll mute myself so it doesn't overrun with a mower.
Great. Thank you so much, Dr. Pribble. Again, thank you to Dr. Soar and April for being with us today. We do have some questions. I will share that there have been a few comments in the chat discussing the frustration with kind of that disconnect between who runs the PSAP and how the MCA interacts with the EMS agency through protocols. So there are some frustrations that are being shared. And I guess that question might go more to Dr. Soar. What is happening with what is there progress occurring in more integration between the EMS system and the 911 Commission in Michigan? Is there work being done?
So the state 911 training coordinators has a subgroup, and they're actually going to talk about the issue of can we require training in telephone CPR, if not require provision. And that's a topic that's on their agenda. Other things that have been helpful is that going back a few years, during the crash of 2008, there was a move to consolidate a number of governmental services across the state. And one of those was 911 dispatch, and there's been a consolidation of 911 centers in southeastern Michigan and elsewhere around the state as well. And I think that probably helps as well.
It certainly does. And April, you mentioned that, a system reporting that they do EMD, I'm going to put up the quote signs, they do EMD on paper doesn't always translate or equal a reality of them doing, the advanced, medical direction and telephone CPR. So we do have another question here from Dr. Kupas. He's intrigued by that about the 1/3 of municipalities use a transfer to a secondary PSAP to get their EMD instructions. Have we looked at the delay specifically caused by those transfers? The delay in getting CPR instructions, first defibrillation or first compression?
So you would think it would be easy to figure out the 911 time and get that from a 911 caller in a uniform fashion. And when we had landlines and fixed telephones on the side of your wall, you could get that data from AT&T fairly easily. Now it's a lot harder. And knowing the time that the PSAP gets the call versus the secondary dispatch PSAP gets the call is a little bit hard to sort out. So it's doable. It's just one more logistic barrier. And of course, if the question is, if nobody's going to do EMD versus handing it off to somebody that does EMD, if it's a minute or 2 or even 3 delay, it's probably worthwhile to do. So
right.
I don't think anybody has data on, is this better or worse than not have secondary PSAPs, but a lot of telephone CPR gets provided in Michigan by secondary PSAPs, so that's a good thing.
Excellent. Yes, it is. So you mentioned also that the dispatch centers can enter data into the carriage registry that's very specific to their performance. How do we, do you know of any strategies, or how can we, from a granular, a county level, increase or encourage our dispatch centers to put that data in? Because I think it is crucial, as you've mentioned. So what can we do to increase that?
Yeah, so it's kind of interesting because the dispatchers don't have a CARES account, and it takes a little bit of work to work with Terry to ask, for example, Roseville and Macomb County gave Sarisa, which is the secondary, which is a primary PSAP, but it's their PSAP provider, had to give them permission for Terry to give the Sarisa, the dispatch center, access to their data. that also gives them access to identifying all the cardiac arrests. So I think that's a key piece of being able to provide that information back and forth. So at the risk of creating more work for Terry, CARES is a great vehicle for giving PSAPs access to all of their cardiac arrest data cases.
Fantastic. We do have time for one or two more questions, and I want to share some. Go
Luke,
ahead.
let's just do one more question real quick. Maybe we can get a quick little break here, but one more quick question.
All right, sure. That is, we'll give one for sure from Dr. Newmar. What can we learn from other states? Their best practices for optimizing delivery of telephone CPR. I mean, are there strategies to work with other states ongoing right now? It's for either April or Dr. Spoor.
So you're asking if Michigan is working with other states to on these strategies. I'm not aware that anyone in Michigan is actually working with other states right now, but it definitely is a good idea to see how the two correlate. A good one to work with right now would be, for us in particular, would be the state of Wisconsin, to see how their telephone CPR legislation has changed the response within their state.
Outstanding. So I'll just wrap up with a quick thank you to Dr. Swore and April. We do have a quick comment from somebody who works in the state EMS office, and they state that due to a relatively new 911 director being in place, that the EMS office has been working closer in the past year than ever before, working together, bridging that gap between 911 and EMS. So hopefully there are good things on the horizon in Michigan. Again, thank you, Dr. Swore. Thank you, April, very much for being here today. Dr. Pribble, back to you.
Yes, thank you very much. We're a tiny bit ahead schedule, so we're going to break for a few minutes just so people can use the facilities if need to or stretch their legs. We'll reconvene back at 11 o'clock, which is like 4 or 5 minutes from now. I'm going to post the poll question for the third section. You can answer that if you're here at your screen. Otherwise, we'll see you back at 11 o'clock. Okay, welcome back. It's 11 o'clock, and we're going to start the next section of our conference, focusing on the EMS link in the chain of survival. We went through the poll question, and a lot of people are willing to do what it takes to get hands on the chest. Hopefully we can understand how to do that more safely going forward. What I'd like to do is introduce our next speaker, is Dr. Newmar. I'd like to bring him back again to provide more of a deeper dive into the Michigan CARES data for the EMS outcomes. So we have a framework from which to build on in these next two presentations. So I will stop sharing my, my screen, and Dr. Newmar, you can take over.
Okay, thank you. Does that look okay from the slides?
Slides look good and your video is on, and you sound great.
Excellent, thank you. So again, to dive a little bit more deeper into some of the data from the past year, focusing on the EMS response and what we can learn from what happened in the past year. As I mentioned before, our ROSC rate, a return of spontaneous circulation rate, saw a decline down to 25.6%. That decline was similar to what was seen at the national level. And I talked a little bit about how, when we look at percentages versus absolute numbers, that our number of patients that had return of spontaneous circulation was similar given the same number of reporting agencies. But the proportion decreased, which means also the denominator, or the number of EMS treated cardiac arrests, increased. Similarly, our survival rate saw a decline down to 7.1%, and that rate of decline was similar to what was seen at the national level, although our numbers are below the national level. And then if we look at survival with good neurologic function, that's the same pattern. This is people that survive with a cerebral performance category of 1 or 2, which means they're either normal or have very limited disability, but still can go back to work and do activities of daily living. And that number fell to the lowest we've seen even since we started, down to 5.8%. If you look at some of the other data on a monthly basis, one of the things that's important to look at is the proportion of cases that are a shockable rhythm, because a shockable rhythm has a much higher rate of return upon spontaneous circulation and a much higher rate of survival. And part of the concept, at least for COVID, would be that if patients were having out of hospital cardiac arrest primarily due to COVID, it would be more of a respiratory arrest and likely precipitating more of a PEA or a systolic arrest. But we really didn't see a dramatic change in the proportions. There was some signal here where if we were sort of averaging around 12 or 13% or 13 to 14% in April, when we had the highest sort of rate of COVID, we did have the numerically lowest proportion of shockable rhythms. That didn't seem to be as significant in the second wave here, where we were in November, December at about 14%. So not a lot to learn, I think, from any significant change in the proportion of patients with a shockable rhythm. We did see, and this was similar to what was seen across the country, a significant rise in field termination that was related to the various peaks that we saw. Most significantly was in April, where we had started the year with field terminations around 42%, went all the way up to 70% in April. That came back down over the summer and then started to go back up a little bit, but not nearly as much in December, where we were seeing our secondary peak. And I think part of this was there was a state change, and I think Dr. Fales is going to talk a little bit about the changes in the statewide guidance for termination of resuscitation rules. And this is something that I think is important to look at as we move forward and emerge from the pandemic. Certainly appropriate use of field termination of resuscitation rules is a good thing in terms of, and sometimes those are underutilized. So that's something that we need to pay attention to, but also we need to look at whether our changes in field resuscitation rules were something that could have contributed to some of our results. And then finally, I'll end again on some data on the variability and disparities across the state. Again, these are data from CARES reporting agencies with at least 50 non-traumatic cardiac arrests in 2020. And this is the return of spontaneous circulation rate, ranging from as low as about 5% to all the way up to over 40%. So almost an order of magnitude difference in the rate of return of spontaneous circulation across the state. And this again points out I think a real opportunity of what first of all, it demonstrates that high rates of return of spontaneous circulation are definitely feasible, with this top quartile all having a return of spontaneous circulation rate above 30%. And what we can learn from those systems in terms of that could potentially be translated across the state to bring up our overall mean. Similarly, we see significant disparities in our overall survival rate as well, as low as 1% and as high as 16%. And if you remember from our original goals for 2020 of doubling cardiac arrest survival by this time, our goal was to get to around 16% for the entire state. And what this data tells me is that that number is not impossible, that there are several transporting agencies in the state that are achieving that kind of survival rate. And what we can learn from those agencies, we might be able to translate across the state population for everyone's benefit. So with that, I'll end with the same message that moving beyond 2020, we have to reset our goals, and we need to think about during this conference and in the year ahead, what kind of SMART goals we want to create for moving our system forward and improving outcomes for out-of-hospital cardiac arrest and ultimately saving more lives. So with that, I will stop my share and take any questions.
Thanks, Dr. Newmar. Again, showing the variability, and I put that comment in the slide with variability comes opportunity. So really kind of diving into understanding where the opportunity lies with those lower or higher performing kind of areas. Is it something that's geographic? Is it something that's, systemic? Or is it something that is with resources or training? Those are really areas that we probably need to focus on going forward to try to identify where we can really impact. So with that, I don't know if I see any more questions in the comments. Let me see. There's one by Dr. Kupas. In the survival rates by agency, did you require a minimum number of arrests before including the agency on the graph? Agencies that have a small number can look good if they have a couple lucky survivals.
Yeah, so on the graphs, it was listed there that you had to have 50 treated arrests to be included in that. So it does not include agencies that have one or two arrests each year. The other thing I wanted to comment on, and I think it was in the chat from Dr. Swore, about public reporting. And I think that's something that really is potentially something that is it's a sensitive topic. It's something that we need to certainly discuss. But is that something that right now everything we do in CARES is voluntary, which is important. Everything we do is for quality improvement, and each transporting agency gets its own data, and that's important. But sometimes public reporting of data will also create access to resources. So if we are able to utilize these differences that we see to go to the institutions or governing bodies that are related to the areas where the numbers are lower, that could be a mechanism by which we could gain access to resources to help quality improvement efforts. So I'm just throwing that out there for something we might want to discuss in our subsequent panel.
Great. What we'll do is move forward to the next speaker. I'll share my screen real quick before we bring on Dr. Salhi. All right, our next speaker is Dr. Rama Salhi. Dr. Salhi is a national clinical scholar at IHPI and a clinical lecturer in the Department of Emergency Medicine at the University of Michigan. Kind of continuing the theme of variability. She will be presenting on research she has conducted regarding enhancing pre-hospital outcomes for cardiac arrest during COVID. So Rama, you can go ahead and start sharing your slides. I will stop my share.
Right. Thank you, Dr. Pribble, for the introduction. Can you see my slides okay?
Yes, looks great.
Perfect. Sorry, I started, this is a spoiler alert, I started from the wrong slide. So thank you, Dr. Pribble. I'm really honored to be here with you today. Today I'll be talking about our ongoing study, the Enhancing Pre-Hospital Outcomes for Cardiac Arrest, or EPOC, and continuing the theme of other speakers, really thinking about our findings and the implications during COVID. Just want to mention here that the study was funded by the NHLBI. And before we really dive into the COVID specific work, I just want to kind of orient us all to the project at large. So the study is aimed towards identifying best practices to increase cardiac arrest survival, specifically from a systems of care perspective, getting buy-in really from multiple stakeholders. This was completed as a multi-step process that I'll briefly, as I mentioned, orient everyone to before we really spend the majority of our time in phase 3. So phase 1 was actually Dr. Newmar set up quite well for me, was identifying the variation in cardiac arrest survival among EMS agencies in Michigan. Phase 2 then goes on to identify best practices, for cardiac arrest survival in emergency medical systems, looking at agencies with both high and low survival. And then phase 3 validates those best practices for survival with a goal towards compiling this in an EPOC toolkit and disseminating it more broadly. And I will briefly mention here that this EPOC toolkit is due to be released as a RAND report in fall of this year, which we're really looking forward to and hopefully you'll keep an eye out for. So thinking about results from phase 1, we analyzed 4 years of MyCare's data, which showed results very similar to what Dr. Newmar showed. The mean survival rate was approximately 25%, the highest, 7 highest cardiac arrest survival agencies having a mean return of spontaneous circulation of 40%, the 7 lowest having about 10.8%. So really confirming that that finding persists over several years. In phase 2, we went on to conduct focus groups in 9 communities across Michigan. And when we visited these communities, we talked to dispatch, 911 call takers, EMS, police, non-transport fire, as well as emergency departments to really get as many perspectives as we could. Key findings really demonstrated much of what we know. Multidisciplinary training is important. Quality improvement, continuous quality improvement is important. Dispatch assisted CPR is very important, as Dr. Soar and Ms. Hines mentioned earlier. But really, it also brought forward to us the importance of information sharing of these best practices. And a common theme that we saw, in addition to the dispatch assisted CPR kind of just come up over and over again, was hands-on CPR. And this really motivates us, among other things, to rethink and critically think about time to CPR from both a lay person and a responder perspective in the context of COVID. At the same time as all of our work was happening, we know that a lot of other important work was happening. Specifically, I want to highlight what we heard Dr. Sue talk about earlier, looking at CPR and defibrillation, which are really our among our 2 best tools as potential aerosol generating procedures under certain conditions. And this really begs the question is, knowing that every minute of delayed CPR is directly correlated with decreased survival, how do we begin to walk the line between patient care and provider safety? As such, it becomes even more critical to understand what's happening on the ground, which kind of brings us to phase 3. Phase 3 more broadly focused on overall validity of the best practices that we identified in phase 2. But given the onset of the pandemic, we also included questions to contextualize how this has changed in the setting of COVID. So we sent out surveys to 312 total agencies in the state and got a response rate among CARES participating agencies of 80% with an overall response rate of 67%. So pretty good snapshot over this kind of 150-day period that we had the survey open. And again, as I mentioned, had 9 COVID-specific questions nested in the much larger survey to understand the impact of the pandemic on cardiac arrest response. We've in preliminary analyses seen some really important trends emerge. So 64% of the agencies that we surveyed reported having staffing shortages. And what's more is, when asked what contributed to these shortages, many of them cited mandatory quarantine, illness, COVID-related concerns as contributing significantly to these staffing shortages. In addition to this, as another important layer, really requires us to consider the equipment to keep providers safe while still providing care. So we went on to ask them if they were running low on any infection control or other COVID-related patient care supplies, and this would include perhaps supraglottic devices. And 23% of the agencies reported running low on those supplies. And then when asked what supplies they were missing, really what came forward was the resources needed to keep providers safe. PPE, disinfectant, specifically N95s and surgical masks really came forward. Not surprisingly, we also saw the pandemic impact our pre-hospital practice patterns as well. Really striking here was that the first 2 bars, approximately just under 30%, either stopped intubating entirely or stopped intubating potential COVID patients during the pandemic. Sorry, having a little computer glitch. Okay, there we go. Considering all of this together, there really are a few key considerations that I'd like to bring forward and use these to kind of motivate the ongoing discussion that we've had here today. So first, we saw that similar to other regions and prior studies, Michigan has pretty significant geographic variability. Our study supports the importance of timely CPR from our qualitative interviews with our providers on the ground, and really contextualize the barrier that the COVID-19 pandemic provided in the provision of timely CPR, specifically with respect to provider safety and disease transmission. Given the concurrent staffing shortages and PPE concerns, really highlighted the importance of this conference, frankly, but really thinking about cardiac arrest from the view of the whole system and being creative about leveraging all partners. So what does this mean for the future of cardiac arrest care when all is said and done? As I mentioned, it brought forward kind of the importance of innovation and creativity, and brought to the forefront the importance of being able to quickly disseminate knowledge and resources, both in a pandemic, but also really within our existing systems and structures under normal times. So we really need to consider how we rapidly integrate and disseminate research, for example, that informs providers about safety against infection during resuscitation, so that we as a system can better understand resource priorities. COVID has also really highlighted the need to think about perhaps underutilized forms, such as dispatch-assisted CPR that we again heard about from Dr. Sor and Ms. Hines earlier. And really thinking about how this could be expanded in a number of ways and how that could be imagined. It's important for us to continue community efforts, as Dr. Newmar spoke about earlier, to decrease time to CPR, with an eye towards how we can support the great work that's already being done in the state, and while simultaneously supporting the technological advances in PPE and other things that support provider safety, such as patient hoods, patient masks, and other innovations that are going on. But really, given the expertise that's in this room, I would love to continue the conversation that's been happening and pose the question to you as experts in the audience as what you all have been considering, whether it be as individual practitioners or for your larger department or agency. And so with that, I'd like to open it up to any questions or conversation on critical implications or next step for cardiac arrest.
Rama, thanks so much for that great talk and all the work that's being done with EPOC. I think this is a great, program that will answer a lot of those questions that we talked about earlier with Dr. Newmar, trying to understand that variability. And I want to welcome Mashida Beer. She's the director of the EPOC collaboration for question and answer as well. One thing before I turn it over to Tony for some questions from the group, going back to community involvement, it looks like the EPOC study is very heavily community involvement. A lot of that is part of your study. How do you select which community to kind of go into, and how do you make that first connection? I'm trying to think about how do we, as Save My Heart, make connections with communities for issues that we think are important.
Yeah. So a couple things. I just want to, I apologize for not mentioning Dr. Abir and Dr. Nalmuthu are the PIs of this fantastic study, and have been really privileged to work with both of them. But to answer your question, the way that this was structured in this study was really informed because we wanted to get at what these best practices were, what those top survival agencies were doing differently, as we kind of stratified it, looked at the high and low survival agencies and spoke to them directly. And so made contact with them, and much of the networking was done by Dr. Abir, so perhaps those nuances can be spoken to by her. But that was kind of how we selected the agencies, really so that we could see what those differences were to distill them into the EPOC toolkit.
Just dovetailing on what Rama said really quickly, we also factored in geography and urbanicity. We wanted to make sure that we capture urban, suburban, and rural communities. And we were very fortunate to have Chief Bill Forbush as part of the study team, who truly facilitated connections with various CMS agencies across the state, as well as Ms. Kathy Wall at the Michigan Department of Health and Human Services.
Thank you for having both of you on at the same time. If there's anybody that has any questions, please put it in the chat, but I do have a couple myself. So you brought up the concerns of staffing shortages actually being more prominent than even PPE shortages. I know that there's a toolkit being developed for addressing the variabilities between the EMS agencies, and of course there's the opportunity of the toolkit. What has come up, at least amongst the EMS staffing agencies, about how to deal with this staffing concern?
Yeah, so this particular question was done in the form of a written or telephone survey. And so much of the information we got was from the multiple choice or free response. And a lot of the things that people cited were specifically like wait times for testing to return to work, and then fear of contracting COVID and PPE. So I think really the big thing kind of highlights what a lot of other folks have said is prioritizing the safety of our frontline providers to do what they can do. And then as new technologies come out, so for example, like many hospitals in the state now have rapid COVID testing, is how do we make sure that our providers have access to those sorts of things so that they can both be safe and return to work as soon as it's appropriate.
I was hoping to hear something like, we are making sure all of our providers are vaccinated so they don't have the fear of getting infected. But I understand that that is a real big bar that we're going to have to face once the FDA approves the vaccine. There's another question on the chat about, is there a correlation between the airway management strategy with the rest of the global trends of using supraglottic airways in out-of-hospital cardiac arrest?
So I just want to make sure that I understand correctly. So there is certainly this trend towards supraglottic airways rather than endotracheal intubation. Could you restate the question? I'm not sure that I completely understand.
So I'll state it another way. There's, at least in Michigan, the emergency protocol for using supraglottic airways for intubating those who are presumed or suspected of being cardiac arrest. Are we using that in other methods as well, or is it only for the suspected and presumed COVID-19 patient?
Yeah, so it depends on the agency. These specific questions were targeted towards COVID, so I can't really speak to that overall trend outside of it. I will also just kind of, I think I mentioned this briefly, but kind of mention that this was really a snapshot from October to March of this year. So just as the vaccine was rolling out, and really just a snapshot, and it's hard to kind of comment on overall trends before and after the pandemic just based on the data we collected. And I don't know if Dr. Beer has, yeah.
Sure, no, what we are doing another project that Rama was involved in around understanding the root causes of vaccine hesitancy. And we are interviewing pre-hospital providers as part of that. So, maybe in a couple of months, we'll have an answer there for you.
Yeah.
That's great. Hopefully, yeah, that is great. Hopefully by July 1st, we'll have, we'll be at a certain immunity level that hopefully things will be moving beyond COVID. Yeah. I'll give it back to Jim at this time.
Yeah, thanks so much, guys, for a great presentation and great lively discussion. I'm going to share my screen one more time before we bring up our last set of speakers here. So again, want to just appreciate everyone's questions in the comments in the chat. Really help kind of facilitate the discussion. We'll be doing more of that as we get to the discussion section. But I want to introduce our final presentation, formal presentation, and this will be a combined presentation. So I'd like to introduce Dr. William Fales. Dr. Fales is a professor of emergency medicine and chief of the Division of EMS and Disaster Medicine at Western Michigan University School of Medicine. He also serves as the state medical director for the Michigan Division of EMS and Trauma and as the Kalamazoo County EMS medical director. Also speaking during this session is Emily Berquist. Ms. Berquist is the Medical Control Authority Coordinator for the Michigan Department of Health and Human Services Division of EMS and Trauma. Together, they will be discussing state EMS protocols during COVID-19, what we've done and where we're going. With that, I will stop sharing and let you guys take it from there.
Okay, good morning, everyone, and thanks for having us. We know what we're gonna talk about, so I'll skip that first slide. As far as disclosures and conflicts, we don't have any disclosures and conflicts. These are our list of jobs. You see Dr. Fales's is much longer than mine, but there's nothing to disclose in regards to this presentation. I'm just going to start off and talk a little bit about the protocol process. When we first started hearing of cases around the world, actually is when the protocol process began. And that was long before we had a patient in the state of Michigan. And so we planned for surges. That was the first thing that we did. And I know this is very small, but our first protocol, which is on the side here, we enacted on February 6th of 2020. So a full month before we actually had any patients in the state of Michigan. We also spent quite a bit of time reviewing past data around cardiac arrest patients, specifically cardiac arrest patients that were associated with fevers, respiratory conditions. And then we actually worked collaboratively with the CARES organization to look at outcome data as well, so that when we made the decisions to change the treatment protocols, we were doing it based on the best evidence that we could procure at the time. And then we released protocols kind of as needed. We continually throughout the pandemic have released protocols. We began with destination. We did a lot on privileging. We moved to different personal protection equipment. Then we moved into treatment, and we kind of cycled through like that. So when we release the protocols, they go initially to the medical control authorities as the primary release. We post it on a specific webpage that we launched. It's michigan.gov/EMS COVID, so that people had one singular place that they could go to get a whole bunch of different information regarding EMS and the coronavirus response. So the protocols are there. There's some other guidances that we have released that are also there. We reviewed them continuously. We received feedback around the clarity of the protocols, around what was working and what was not working, around, well, the CDC guidance changed, this hospital's at capacity, how do we move through those things? We reviewed them continuously, and then we re-released and or added new. So we started with one in February of 2020, and now we have 14, the most recent one being February 26th, I think was the last, or March 26th was the last release. And I think it's been 15 separate releases. So sometimes it was a new protocol, sometimes it was revisions, but we've continually changed and adapted throughout that process. So what did we change specifically around cardiac arrest? That's what people are here to talk about. One, full PPE for all resuscitations, regardless of suspected status of COVID. We changed to try to keep as few providers near the patient as possible. So before COVID, when a cardiac arrest was worked, kind of everybody was right in that vicinity around the patient. We tried to get people to move further away, not leave, but move further away to keep themselves a little bit safer. We focused on airway management using supraglottics as opposed to intubation, avoiding CPR in enclosed spaces, specifically ambulances. We don't want people doing CPR in ambulances. They are very poorly ventilated. Even if they have a ventilation system in the back, they're not super successful. And then specifically patients who were in cardiac arrest that appeared to be completely unrelated to coronavirus, we wanted them otherwise to do the exact same thing that they would do on a regular day. So we wanted them to work their arrest the exact same way for the same amount of time with the same quality CPR, just with some precautions around that. But if the patient is suspected to be a coronavirus patient, We did decrease the resuscitation time on task in order to, well, primarily based on the fact that all of the data that we looked at for people who were in cardiac arrest related to a fever, the survivability was very low. So that is why we decreased that time to decrease their risk in doing the CPR on those particular patients. So patients who were suspected coronavirus, they were not to be transported to the hospital if they did not have a pulse. No, again, CPR in the back of the ambulance with a suspected COVID patient is very, very risky. So I know that we've talked about a lot of data that is clean data from the CARES registry. We do have a lot of other EMS data that is, we were joking around when we were working in the presentation, it's dirty. It's not a repository. We can't clean it especially well. But what I wanted to just generally note, looking at ground transport units specifically, so we're not looking at first response data, we had a pretty significant increase in total cardiac arrests. So this includes also dead on scene patients, which CARES registry data does not include. So these are patients that did not receive any sort of resuscitation whatsoever. So while we did see a decrease in overall volume for our providers across the state in 2020 from 2019, we saw a pretty significant increase in out-of-hospital cardiac arrest. So that's a pretty significant jump there. And so I'm going to transfer over to Dr. Fales. He's going to talk about where he's going to lead us in the future, but that's how we got to where we are right now.
Great, thanks. Thanks, Emily, and good morning, everyone, and thanks for participating in today's conference. I think every year when we do this, hopefully we always learn, and I think I would agree with Dr. Newmar's assessment that our numbers are not where we wanted them to continue to trend and go in the positive direction, but that little thing like COVID kind of got in the way, and the real challenge now is how do we get back on track and really start to make progress, as hopefully, God willing, COVID will start to phase out, although I think many of us believe that it's going to be part of our lives for the future. So as we talk about these, where we're going with state protocols, what Emily described was emergency protocols that the state promulgated, as on an ongoing basis from even before COVID hit Michigan. And I think what we're looking at is how do we learn from our experience with COVID, take the things that are going to be probably universally applicable to some degree, and apply them as we move forward. In some ways, we want to be able to kind of have our cake and eat it too. We want to be mindful of personnel safety, at all times for everything that we do in EMS. But at the same time, we can't let that get in the way of out-of-hospital cardiac arrest. That last poll question was interesting to see the response. And there's a couple different ways you could probably view that question. I'm not going to let personal safety get in the way of diving in and doing good quality CPRs. You rip your N95 off, and so you can breathe effectively as you're pumping. That's not really exactly what we want, but I think it was interesting to see that there was the majority kind of agreed or strongly agreed or agreed with that statement. So we want to have that balance between keeping everyone safe and at the same time improving care and getting to that doubling of survival that we've been striving for. So with that said, really what I'd like to do is talk just very briefly on three kind of focus areas: responder safety and PPE, airway management, and then termination versus continuation.
Dr. Fales, you're
Bill?
muted. I don't know how that happened, but you're muted.
I
I did not
yeah.
do it this time.
Yeah, many would like to, yes. Hopefully just muted for the very last comment there. We don't have to redo the slide. That would be really painful.
No, it was just right when you were changing slides.
Must have accidentally hit the button or something. So talking about responder safety and PPE, I think one of the things I worry about is as we see the numbers starting to decline, again, God willing, from our current spike, it's just so important that we really continue to emphasize not being complacent with PPE. I'm totally dating myself, but I can recall when I started relatively early in my career, not when I started, but early in my career was when HIV emerged. And at the time, the only place you would find a pair of gloves in an ambulance was in the OB kit. And I remember, hearing a news broadcast saying how healthcare workers might have to wear gloves all the time. And we kind of laughed and said, yeah, that'll happen someday. What are they going to put a box of gloves on every ambulance? And, just within a relatively short time, that became the norm. So I'm kind of thinking we may be there with respiratory protection, especially with procedures like CPR, until we have at least a better idea of what risks that might place on responders. So respiratory protection, I think will remain for the foreseeable future, whether it's N95 or a face mask, may change, but certainly the work of breathing is more intense with an N95 on the part of the compressor, and that really questions, does that have any adverse effect on the quality of those compressions? And for those researchers on the meeting today, just with a good high quality recording CPR band, I think it'll be really interesting to see if we can see if prolonged CPR with an N95 is results in less or slower or less deep compressions. So in any case, I think that's something we have to be just aware of, and that we still are in a world where we're using respiratory protection for the foreseeable future. And that will likely still stay in protocols. And as we talk about these protocols too, we're talking about really transitioning to long-term protocols as we go to the newest iteration of our state protocols, not the emergency protocols that Emily talked about. Then, one of the other things was minimizing the number of responders in close proximity to the patient. I think that again is kind of becoming a best practice. And as an EMS physician who regularly goes out to cardiac arrests, I've always been amazed at how many responders we can sometimes fit in a confined space of a bedroom, not to even mention a bathroom. And I think with this protocol that we've had in place, the emergency protocol, really trying to limit the number of people, in the hot zone, so to speak, is good, not only from a safety standpoint, but actually we've heard anecdotally about how it even improves the efficiency of the team, having the relief compressors loosening up and stretching out in the next room and not crowded into the active resuscitation area. And then resuscitation safety officer was in one of our, I think, more recent revised protocols. And this is having, it's no different than the safety officer on the fire ground or on extrication at a car crash. It's having someone whose ideally primary responsibility is just making sure that everyone is staying safe. And not only does this benefit the responders, but it also can benefit the patient. They can be really focusing on good, safe practices. So that does not mean that that we're not all responsible for safety. And I think we have Dr. Kupas, a good friend and colleague from Pennsylvania, on the call. And I think next week we will be doing a webinar on EMS safety, which will be exciting. So we'll keep on going. The other area is airway management. And I posed a question to Dr. Salih and Dr. Abir, great presentation as always, on any feedback on the supraglottic airway use that was encouraged particularly during the pandemic. For a number of years, we've kind of allowed both endotracheal intubation and supraglottic airway. I think we've increasingly been stronger in our state protocols, saying that supraglottic airway should be considered at least equivalent or not inferior to the to endotracheal intubation for pre-pandemic cardiac arrest management. And now when we put the emergency protocol in, it says, probably the up close and personal getting down there and trying to do intubation with a potentially COVID patient is not a good practice. So our hope is that that agencies that have not used supraglottic airways first line, will reconsider that as we start to emerge out of a pandemic, that may be a best practice that we want to keep. It certainly is supported by increasing evidence in both the PART trial from the Resuscitation Outcome Consortium, as well as the Airways 2 trial, the UK trial looking at iGel airways. And the question really is endotracheal intubation today in 2021, regardless of the pandemic, still the best option for time critical resuscitation of out of hospital cardiac arrest? And perhaps this might be system dependent. Small groups of paramedics that get large numbers of intubation, that have all kinds of adjuncts that can help them with the procedure. Maybe they can do it as effectively, but I think for most systems, I think we're starting to learn that supraglottic airway may actually be a better way to go for this population. And then finally, the debate about termination and versus continuation of resuscitation. And this was one that, the intent of the short termination in identifying futility, particularly in someone that had clinical features associated with COVID. They had a pre-existing fever, they had a cough prior to arrest, they had a known exposure to a COVID positive patient, those kind of things. And they present in asystole, those are the ones that we really were saying, those to protect responders and recognize that we believe these are relatively futile cases to limit that duration of resuscitation. That said, I think, and there's many agencies that did that, as Dr. Newmar mentioned, our tour rate increased significantly in Michigan. And again, going to Dr. Kupas, I think he's done some work in Pennsylvania looking at time on scene, and the longer EMS agencies tend to spend on scene working resuscitation, sometimes it's a correlation with a better outcome. Agencies that have more aggressive field termination rates also somewhat paradoxically or not have better outcomes. So I think these are two terms that are interrelated. I think the termination is in those patients that we've worked the resuscitation appropriately for that patient, and we recognize that a rush to the hospital is not going to change outcome. And in the patients that are, again, appropriate, that we continue to do that full court press and try to make the most out of that. So that really is, sometimes we look for a quick time answer, but it really is on the totality of the clinical condition of the patient to make those decisions, ideally with good medical insight. So thank you very much. I think we're at time and getting ready for breakout sessions. But I think as we talk about these protocols for the EMS group in particular, hopefully what we hear at the breakout session will help inform what our next iteration of state protocols will look like. Thank you.
Bill and Emily, thank you so much for a great presentation. This is such a great topic. I want to open up time just for a question or two, even though we're kind of at time. So Leslie, can you grab a couple questions, maybe two quick questions from the comments?
Sure. Yeah, thank you very much for your presentation. A lot of moving parts, obviously, with COVID. One great question was there a difference in time on scene for suspected versus non-COVID over the past year?
I think we don't really have a great way of measuring that. I think it's a great question, and I think we can probably dive into with one of our tools, biospatial, looking at COVID, cardiac arrest, and non-COVID, and seeing if we can find that information out. I think anecdotally, I think we did see shorter times for COVID patients, but I don't think we have that well defined yet.
That's understandable. I'm sure a lot to come there. We'll do one more quick one. Here's one from Michael Smith. What should we do with a resuscitation in a public building or parking lot that won't ROSC and termination is recommended?
Yeah, that's a great question, aside from COVID. And I think when you have a patient where you've come to the point of futility, the idea of terminating is what's the right thing to do. If you're in a public venue, then there may be a variation of that where you may, and this is going to be based on your local protocols and policies, you may consider termination after you've loaded them in the back of the ambulance and transport without CPR to the hospital for official pronouncement. but and that's done around the state in a number of places. So
yeah, if you don't mind, Dr. Fields, there are the system protocols specifically around what to do for that, and each MCA is a little bit different based on system resources. In essence, if you have the resources, moving them to the back of the ambulance and then transporting them back is a great option, but it does definitely depend on the different systems, and each MCA has a little bit of a different take on that.
We do not recommend putting like little orange cones around the body and tell people to avoid aisle 6. That's really a bad practice, we think.
Great, thank you. Go ahead.
Terrific, guys. So as Dr. Fail says, I think we're going to move on into our discussion and final reports. So for the next 45 minutes, we want to take everyone's expertise and use all of the people here and try to find real important topics that we need to address moving forward. So now it's time to take all that we've learned and discuss our next steps. We'd like to use this time to have a discussion on what issues are important to improve out-of-hospital cardiac arrest in the areas of community response, including 911 dispatch and EMS. We're going to start the session with community response, 911 dispatch, and telephone CPR. The facilitator for this discussion is Dr. Tony Su. So he's going to be highlighted. Panelists for this session will include Dr. Cindy Su, Dr. Newmar, Dr. O'Neill, Dr. Swore, and April Hines. So if you all can undo your video so you're actually shown on the screen. This is meant to be a very interactive session. So please utilize the chat function. There's going to be some people who are going to be monitoring Q&A to post your questions. And your questions will be moderated and asked of the panel. The goal of this session is to identify the most important issues that we can address as a community to improve out-of-hospital cardiac arrest. So I'll let Tony take it from here for the community response 911 dispatch section, and I'll pop in when we're ready to move to the EMS.
Thank you very much, Jim. So Dr. Newmar has presented a few times about what he feels is our goal with this panel. Number one, we need to be specific. Number two, we have to think about measurements. Number three, is it attainable in the next 5 years? Number four, is it really realistic based on what we've seen over in the past 5 years? And then lastly, we need to think about the time-based approaches to it. So I'd like to have Dr. O'Neill start. You'll have to unmute yourself.
So I guess the first question is define community. When you say community, so this is untrained personnel, correct?
Yeah, so as you were highlighting, Dr. Dunn had gone out into the community and done some specific training.
Right. So what we had done, so we geocoded our whole area and we looked at the rates of cardiac arrest within plots. Basically, we used tax coding. And then we looked at the rate of bystander CPR. So those that had the high rate of cardiac arrest and low rate of bystander CPR, we targeted those communities to go in there and actually train CPR. And it was a multitude of efforts where it was, you know, cardiovascular risk screening, hypertension, CPR training, and, you know, our bystander CPR rate has actually gone up significantly. Our bystander CPR rate was just above the national average, even during COVID for 2020. So that has been very effective, and people have been extremely engaged with that effort. And we're continuing that effort now with American Heart, and it takes a city, and that's a two-pronged effort, looking at one, increasing bystander CPR beyond where we are right now, and also for hypertension, which were not surprising when you looked at the very high areas of hypertension, they overlap directly with those with increased incidence of cardiac arrest. Still a lot to do. I think one of the things that's going to help a lot is we are trying to make DPS, Detroit Public Schools, a heart-safe school. Dr. Dunn and his team made significant inroads despite COVID. And I think that's the next step to really bring us well above the national average.
Now, you mentioned geocoding. I know that not everybody understands what that means, and what does it take to get to that point?
So it takes census tract data. It's EMS for hypertension. For the blood pressures, we took EMS where they picked the patient up, use that and track that within a census tract. Same for the cardiac arrest. where the patient was picked up for cardiac arrest. This was put into a map of Detroit from the addresses they were picked up at. And that's how we used our zones for intervention.
So Tony, so if I can comment on Brian's observation that bystander CPR rates have gone up a lot in Detroit, I think that's synergistic with a lot of training, and that the dispatch CPR group, the dispatch center in Detroit EMS has done yeoman's work in trying to provide telephone assisted CPR with Damian Golek and Rob Dunn in the group. And they've really, I think that's a key part of teaching the community, but also reinforcing at the time of the event. So I think that's an important piece of the puzzle.
Do you feel like maybe a toolkit is needed for the community? I mean, we have a great example here. Cindy, comments?
Yeah, I mean, I think, you know, a lot of the presenters have already talked to the importance of really community outreach, but specifically targeting the community that are essentially disenfranchised and underserved. And I think we need to do that by looking at more granular data, as what Brian has suggested, by geomapping or having more agency-specific metrics so that we could report back any really the progress or lack thereof, so that we could target, do more target-specific interventions. I think ultimately, you know, my own work is very quantitative, you know, everything that I do in the lab and focus on actual quantitative data. But I think, you know, everybody really, I mean, I think the mixed methods approach is probably more powerful here. So really giving faces to, you know, bystanders who actually perform CPR and whether or not they saved or not, and their thought process. I mentioned, you know, one of the things that I was involved. So when I was on this radio show, the callers I called in, there was a teacher who was really just pretty distraught, I would say. I mean, she was trained to do bystander CPR, but she had no idea what she would do if a kid were to collapse in her classroom, right? Should she perform rescue breaths, or, you know, what's going on, what's going to happen? And then I think related to COVID, with the pandemic ongoing, perhaps other innovative strategies such as, you know, teaching both dispatch assisted, but also, you know, hands-on CPR virtually, and looking at more innovative approach, say through social media or virtual reality could be effective. But I think we need better ways to keep track of our data and progress.
I think bringing the data to bear when it comes to asking for money is very important. So April, I think you made a comment earlier about funding through legislation for EMS. Do you think that's a big role, and how are we going to make that happen for the community?
I actually, when I was talking about telephone CPR legislation, there really is no funding necessary for that. Telephone CPR, the actual protocol itself is free. There are training modules that are free. The only thing that the PSAPs would have to do is train CPR for the responders, or for the people actually taking the call. And that is already covered under the Michigan, the dispatcher training requirements, that those funds can already be handled. So to be quite honest with you, when it comes to funding for telephone CPR, it's pretty much revenue neutral.
I don't know. What do you think about this, Robert Muir and Dr. Swore? What do you think about getting maybe more money into the community CPR aspect of it, though?
So I think one of the challenges that, you know, we think about cardiac arrest a lot of the time. Most people don't think about cardiac arrest very often. And I think one of our challenges that we have to overcome is that I think the population in general doesn't think that there's a problem that needs to be solved, or at least is not aware that there's a problem that needs to be solved. They're aware of cardiac arrest, but they're really not aware of bystander CPR rates and disparities among those things. So I think one of the things is the data, right? And the data that might be, you know, I'm going to just propose something. So what if we had a map of Michigan that based on, county or whatever granularity you want, showed the bystander CPR rate and the telephone CPR rate. And so people could look and see where they live, is the bystander CPR rate and telephone CPR rate high or low relative to the rest of the state. And then they could go to the leadership in their community or be more likely to be engaged if Save My Heart tries to engage them in terms of improving that. So I think one of the things is motivating the community to solve a problem that they may not be aware of or may not think about.
When I would show the geomapping of Wayne County, the first thing you can see everybody trying to figure out what zone they're in to see whether or not they're getting quality CPR. And often even people in the board would look and say, geez, I'm right in the middle of an area that is dark red for both. So there is an impact there. And I think Bob is asking for a community groundswell. He's asking for boots on the ground to drive that. And I think that's always an effective method.
It's hard to argue against more money, but I would agree with April that we have a lot of the pieces of the puzzle in place. We just have to put them together. And that I think I put in the chat box that, the telephone CPR training is not only is it free, but the state 911 funds will pay for the time for the dispatcher to get the training, so that as long as there's enough people to pay overtime, there's funding for this particular piece. And I think it's an important piece. So
I think it's a very important piece. So, we have somebody that actually did bystander CPR as guided by expertly by the Washtenaw County PSAP, Mr. Robert Lane. He saved one of our people at St. Joe's. But I'd like to move to Terry Shields. There are many questions actually in the chat box, if you can let us know what they are.
Sure, we just had a very interesting question. Could it be more powerful messaging to report no bystander CPR rates rather than bystander CPR rates, especially for problematic outliers? So that's a very interesting way to look at it. We're actively creating a map, and we are locating all of the EMS agencies, the hospitals, AEDs in Michigan, 911 dispatchers. We'll color code it to who's currently participating in CARES. And so this is just another layer that we can put on this map. These are all great ideas. But one comment I wanted to make too is about the fundraising. I was putting in the chat box before, Tony, you brought that up. I think it's really important that Michigan, that we look at fundraising, especially in terms of hiring a statewide community CPR coordinator. We have great resources from the American Heart Association, but it's expensive to purchase the equipment. So I think fundraising really needs to be at the top of our list.
Now there is the geocoding option of Pulse Point. Some people have used it well. I heard mixed messages about it. Does anybody have experience with it, and what do they think?
I don't have experience with it, but I think we should work smarter. And it's nice to do intervention or innovation and try some of this stuff, but the squeeze for the juice on Pulse Point, I don't believe there's data that demonstrates that here. I think it makes sense in places that are urban like Copenhagen, but you could buy a lot of defibrillators and do a lot of CPR training for what you're going to put into a Pulse Point app. Just one cynic's opinion.
Now, if we had, of course, a lot of money, we could do everything, but we don't. And so currently we're being selective. That goes towards Terry's point of trying to use legislation, perhaps, in trying to get more funds, because at our status quo, I know that perhaps COVID turned our performance down a little bit, but I think we need some juice, a little bit of juice nationally statewide as well. Like to have, some other realistic or measurable recommendations from this panel, please.
I don't want to dominate this conversation, but I wanted to respond to Bob Newmar's question about best practices for telephone CPR that are being done that Michigan should adopt. And I think the best places are provide aggressive telephone assisted CPR, and that what they do is they train people that it's okay to be wrong. So I think the Seattle data on, a 56% false positive rate is great. I mean, I think our people need to know that it's okay to be wrong. And I think dispatchers, as you heard April say, dispatchers are really risk adverse and a liability concern. And so they don't want to be wrong. So I think if you listen to people, to calls, and I think that's the other thing that we need to do is the medical control community needs to listen to calls, then you'll find out that dispatchers are very careful about doing things right. And I think that's probably something that is a best practice is the places that do telephone CPR well, don't do it so right. They have high false positive rates. And I think that's an important piece of the puzzle. I think that medical engagement, like I said, is a key piece. And trying to get good quality improvement programs for dispatch centers are probably the other best practice that we need to engage around the state. Most places have EMD programs, but most places have operating rooms and can't take a trauma patient to the OR, or EMS systems have defibrillators and can't get a defibrillator to a patient's side. So there's a difference between having the capacity to do something and doing it right.
Well, I think we can combine Anthony's request with what you're driving at. So Anthony's looking for deliverables. So what is the
Brian? I'm having trouble hearing you. I'm sorry.
Oh, I'm sorry. So what is the penetrance or number or percent of dispatch assisted CPR that's in your community, and gauge that to an increase in bystander CPR? I mean, one of the metrics I looked at that I was a little bit surprised by, it looked like it was about 3.5 minutes it took for dispatch CPR from the time of call to actually hands on chest. And I think that's a metric that we definitely can work on. I don't, the no-go, I'm still trying to figure out the other 2.5 minutes. But I mean, that is a metric you have in your back pocket that I think is key for us to work on.
Dr. Newmar, you wanted to say something?
Yes, thanks. So you're asking about specific recommendations. And I think one way, again, much of what we need to do in quality improvement has to be data driven. And so I guess the question would be, and maybe Terry can answer this, what percentage of dispatch agencies are putting data or filling in the data module for CARES? So we have a good data collection module in place. How can we maximize that of the places doing dispatch CPR instruction? How can we maximize the data entry for that so we can look at where the challenges are and help monitor quality improvement? And to Brian's point, when you think about even just bystander CPR, whether it's bystanders without telecommunicator support or not, what's really most important is not just whether bystander CPR was done, but how quickly chest compressions were started from the onset of cardiac arrest. Because as you see from the example we heard today, if someone goes into cardiac arrest and has chest compressions start within a minute, their chances of survival are way higher than if it takes 5 minutes to get chest compression started. And we even see this in the animal lab. So we know that this is really true and important. So this idea of bystander CPR, yes or no, is only the first level versus how soon it takes to get chest compressions initiated. And it's the same story with defibrillation, whether it's an AED or an EMS, paramedic doing the defibrillation. It's really the time from arrest onset to the first shock or the successful shock that makes a difference. So measuring these, figuring out ways to measure and improve these time intervals is really critical.
I
think the
agree with
public
Dr.
mess-
Newmar. Oh, sorry, Tony. I was just going to say, in measuring time, which is so crucial with out of hospital cardiac arrest, is one of our biggest challenges. And Dr. Newmar had asked the question, how many agencies in Michigan are contributing to the dispatch module? I would say, less than an eighth. It's time consuming to review the calls. It takes a lot of time and effort. And this may be where we can get our medical control authority leadership to really help champion how important this is.
So there needs to be a lot of leadership. It sounds like we're the brain trust. We have to inform the leadership. Other things that I think about in the community, in addition to stepping on the toes, literally, of the EMS group that's to follow us, is simple messaging. So we talked about no go. That seems to work for the dispatchers. Can we bring that forward in our public messaging? So although this is probably isn't a measurable specific, it is a realistic specific. Can we use that message of hands only CPR and the recognition part? We're moving forward, whether it's billboards or text. Someone dropped, not breathing well, not responding. Just go and start compressions. I mean, that essentially, we don't need 2.5 minutes for a telecommunicator to tell us that. We should have that automatically as a bystander. But you're right, it's very hard to do. Any other comments on recognition by the bystander of a potential cardiac arrest patient?
Tony, I think your analogy is a good one. I think no go is a good way to teach somebody to do bystander CPR, whether it's on the phone or not. And I don't know, you've been doing this for a while too. It's not necessarily that easy to recognize when somebody's in cardiac arrest. So I think encouraging people to do CPR and teaching the no go at the bedside is a good concept as well.
Yeah, I agree with Bob. So when I lecture to the medical students, it's no longer Annie, are you okay? It's the no go, and invariably within the next month after that, we have a lot of our regulars come in with chest pain because they apparently weren't breathing normally. But it's very effective, simple, effective, 3 steps.
I do worry now about the bearing of chests. I know that we have, some disparities with regards to women and minorities. Then again, we do need to find out where we're going to put our hands. Any thoughts on that for women?
Well, I think we need to, first of all, start talking about it. There is a lot of taboo and misconceptions about performing CPR and defibrillation on women victims. In general, I mean, I think with all spectrum of not only cardiac arrest, but also medical care. And then at the back end of it is also, goals of care discussion and the rate of withdrawing life-sustaining measures, right? So there's a lot of spectrum across the care of gender disparity and racial disparity. And I think we're just only adding that to the agendas of meetings last couple of years. And so it's certainly still under-recognized and understudied. And with that tied in with funding. So I think we need to better understand what the problem is and how we can better address that. And so that we could understand how we can fix it. I think tied into the other aspects. So we were talking about reporting the no bystander CPR rate, but I kind of look at it more from like, it's a carrot or a stick, right? So I think I mentioned it in the chat box earlier during the day, which is in addition to looking at the top and bottom performers and, with the EPOC study and informing the toolkit, perhaps we can look at also the best improved agencies and communities with bystander CPR and what those communities or schools did to accomplish that. And we can certainly, you start by recognition. So recognizing that these communities were able to excel and what kind of find out what their strategies are, but also perhaps incentivize those that achieve well and also help others research goal. And I think ultimately this all comes down to having adequate funding, and we need to really, go at it from national level in advocacy.
We're going to do great as a state, and we're going to show the nation what we can do. I'd like to wrap this up. I'm going to give it back to Dr. Pribble now to wrap it up.
Thanks, everybody. This has been a really great discussion about community response, 911 dispatch, telephone CPR. I'll highlight some quick points. What we're going to do is we will, as a group, kind of go back through this conference and really pick out those key points. But just hearing through and kind of scribing what the discussion was, some key points are going to be really try how do we identify the underserved, and how do we measure their outcomes, and how do we improve those outcomes, whether it's geocoding, try to find partners in those underserved communities, talk about their issues so people are more comfortable with them. We're going to talk about data, trying to increase the number of dispatches that fill out cares, trying to really identify true bystander rates and time to compression, those types of things. We're going to look at telephone CPR, maybe have a map, and then try to find, differences in those various structures based on primary PSAPs versus secondary PSAPs. Try to identify maybe their TCPR rate and also their bystander CPR rate, and then all under the umbrella of fundraising. So it's all going to take a little bit of money, but how do we do that and leverage our group as Save My Heart and the surrounding community to raise some money. So we will formalize that, and that'll be on our website with these kind of take home points that really were formulated by everyone here today. So I appreciate everyone's input and really want to thank the panel for some really great discussion. I want to move on for our last section of the day, and this is going to be the EMS portion of the discussion. Dr. Fales will be the facilitator for this section. The panelists will include Emily Berquist, Luke Bowen, Dr. Rama Salhi, Dr. Dunn, and Dale Berry. And Dr. Fales will be the facilitator. So similar to what we did with the community response, kind of bring up some discussion points, what we think might be some interesting topics, and kind of have some discussion. And what we'll do is have a Q&A with the group at large as well. And Bill, you can take it from there.
Great, thanks, Jim. So unlike the previous panel that I believe April was the only actual telecommunicator here, at least we have a couple of paramedics on our EMS group. And we have Dale Berry, paramedic emeritus, I think we would consider him. So EMS has an important part in out-of-hospital cardiac arrest. I think we agree. It's the bystander CPR is it's all part of a team, but as it relates to EMS, and we have both the BLS and the ALS component of EMS. That's I think what we really want to try and focus on. I think I'd like to start with. There's a tradition, a saying in the fire service of, many years of tradition unhindered by progress. And if you look at what, we don't like to have that same saying for EMS, but if you look at what, we have traditions. We have, no patient is allowed to die in the United States without, 15 minutes of brisk CPR and at least 5 doses of epinephrine or something. So, how do we start to look at breaking paradigms and looking at what evidence is out there? And, we talked earlier, the whole session today is about kind of in the post or declining COVID world, how do we, what should resuscitation look like? So, with that, let's, some of the areas for EMS, include hardcore clinical stuff that we talked a little bit about earlier, airway management, field terminations, and, epinephrine and things like that. But there's also an awful lot of system management issues. And let me just start by talking about something that seems to be rapidly increasing in terms of its problem state of Michigan. That's workforce. So we have a current problem in much of Michigan at multiple different levels, particularly at the paramedic level, with adequate EMS providers, and that's seen around the country as well. Any thoughts to start out with Luke, why don't we start with you? What are your thoughts on where we're at with the workforce and how that directly relates to our goals with Save My Heart?
Sure. So we are seeing across our system and across the entire region and state a shortage at all levels of EMS provider, especially paid EMS provider at the EMT and paramedic level in all types of agencies, private agencies, and even the fire service. It was not too long ago that if a fire department had a couple of openings, there would be hundreds of applicants for each opening. Now it's hard to maintain a list adequate enough to simply fill firefighter roles. And we talk about fire because EMS is a big part of what they do. So we do have agencies trying to get creative. They're doing pre-hire programs where they'll bring providers in, hire them, pay them during their EMT training. A lot of our systems are beginning to hire people without a paramedic level of certification and then pay them to go to do that. And the challenges of an agency being understaffed right now piled on from the extreme stresses of the COVID response and those issues. It's just really difficult for our agencies right now. We have providers who are doing overtime when they are at maximum stress out there in their provision of care. I was at a fire station several months ago now, for a retirement thing, and we saw an ambulance roll out. And the providers come out and they stop and they put on their suits, they put on their N95s, and all this added layers of stress. And now we have very manpower or workforce issues like you discussed. So how to fix it, I don't know. I mean, the agencies I think are doing their best to recruit. The state is addressing it at a state level. There is a committee or a task force or a work group. I'm not sure what it's being called right now, but it is being addressed. But it really is probably related more to the education of the potential provider, making them understand that they can make a difference, because there's not money to fund more providers outside of what the agencies already have. So it's challenging for sure.
Yeah, Luke, that was some good insightful comments. Dale Barry, you're not too far out of the EMS operation world, and I think you still keep pretty connected. Any thoughts from your perspective?
Well, I think Luke summarized it real well. It's hitting across all different parts of EMS, and there's no short-term answer in sight. I think it's the problem of hiring is all across the world right now. The Wendy's in my town is open from 10 a.m. to 2 p.m. now because they don't have any staff. And but EMS is no different. I think it'll be interesting to see if the response times in the CARES database begin to suffer. And that's probably something that we should look at. But I think that as it relates to resuscitation, that's obviously the highest priority of call that any EMS service goes on. So if there's, I don't think we're into triaging out too many calls yet, but if there's a resource, it goes to the cardiac arrest. And so as I reflected on the whole day today, and this is no different than what I've noticed throughout my whole career, it's trying to get a sense of urgency in everyone. I used to ask new paramedics, if you get a cardiac arrest call, should you run up to the house? And no, nobody runs up to the house. But I said, that's the kind of urgency on these kind of calls, and getting the defibrillator out, getting CPR started, whether it's telephone CPR. It's the sense of urgency. I think Bob Swore several years ago came out and did some analysis at our agency, and call takers, dispatchers don't realize how quickly the time goes by, and getting people to do telephone CPR 3-4 minutes is typical. Way too long. And so there's getting 911 directors to be, to reflect urgency to their staff. And throughout the system, the whole, until you declare that the person's dead, there's urgency all the way along. And I think we, as an industry, if you want to call it an industry, don't always put enough urgency in all of these particular areas. The urgency to phone first. And not call, I don't know what the data is lately, but I know at one point it was like the majority of people called somebody else before they called 911 when grandpa dropped on the ground, so it's that whole urgency and keeping it in the public forefront. And I'm just kind of rambling here, but
when you're retired and have emeritus status, you're permitted to ramble. I'm not retired and don't have emeritus status, and I ramble plenty. Good points, Dale. Just kind of staying a little bit with the personnel theme, because I think it really right now is one of the big crises facing EMS. I think some people have perspectives on resuscitation that much of the heavy lifting of resuscitation by EMS, and I mean that somewhat more figuratively than literally, is done by the BLS component. Whether the BLS component is delivered by paramedics or EMTs doesn't really matter. It's about high quality CPR, simple, quick, effective airway management, which we've now extended out to BLS providers. Rob Dunn, you're in a unique system of our largest city, and also a city that has gone through a variety of different transformations with EMS, from transporting, having at one time all ALS to now a two-tiered model with BLS and ALS. And I know you have a number of arrests that have primarily BLS responders managing them. As we talk about some of the crises facing the workforce around the state, and really at all levels, urban and rural and everything in between, there have been people that have been discussing system redesign, and we may need to, the next generation EMS may need to look different than what we're accustomed to, that 8-minute response time for paramedics or whatever. What thoughts do you have in a system from the kind of juxtaposing ALS and BLS response to arrests?
Well, first, I would like to kind of go back to what Dale and Luke were talking about, because I think there are some opportunities that they didn't touch on. Our state has, in various times in the past, put a lot of effort into focusing on certain other skilled trades like welding and things like that. And we haven't put that effort into health professions in general, and particularly the EMT and paramedic level. So I do think there are some things we can do from an advocacy standpoint that some other states have been more successful at, and really, making this a option for a lot of people, understanding that for many people, including many people on this call, in this conference, that their pre-hospital licensure and work was a stepping stone to something else in healthcare. And we just need to understand that and understand the different career pathways. So getting back to the response framework, certainly data over the years from, Opals to whatever is showing that BLS responders can have excellent outcomes, but it's all about your focus, right? You need to keep that, like Dale was talking about, you need to keep that sense of urgency. You need to keep that focus. And in a very large system, one of the key things that we, don't do as well as I'd like to, but we do better than we used to, is that debriefing piece. Help every single provider to be better. So that's from the call taker to the initial responders to everything in transport. And the other thing that I think is important is we need to be aware of what else we can do to kind of support these changes, right? You talked a little bit about the common saying about unencumbered by progress. There is some cool stuff out there that we really haven't been using. We did a nice trial using some telepresence for some things, and I know in my part of southeastern Michigan, many of our MCAs are expanding this telemedicine, telepresence piece, to help provide some better decision making. I think that there are things that BLS providers can do if you push the envelope with them. We currently have a regular ALS monitor kind of locked into a BLS mode on every one of our EMS units that's a BLS unit, so that we can do, we can do complex rhythm analysis. I can look at these remotely and look at some of what's going on. We allow waveform capnography in our protocols for those responders. But I think that more analysis of what's going on in the field, more shared decision making with the providers at the hospital, and generally improving our level of sophistication helps to support that whole system. And the one other thing that you mentioned, not to monopolize the discussion at all, but the system of care is what's important. One of the things we really have, and we presented this at this conference a couple of years ago, is what happens to those patients with ROSC after they get to the hospital. We have a 10-fold difference in survival to hospital discharge when I do analysis by hospital. And now we have enough years of data to say that these patients actually look pretty similar that are showing up at each hospital in terms of all their factors, but something different is occurring at those places. So I think that's a very fruitful piece of research as we go forward, and we're doing a much more sophisticated project on that now.
Rob, good stuff. Thanks. And hopefully people are also following along in the chat side. We've had some, so Dale, people do listen to you. We've had a couple of really good responses to the pace at which we should go from, stop the ambulance to being at the patient bedside. And Doug Kupas, followed by Jason Coleman, because we are a multi-state conference, really. We have Pennsylvania and Florida here. Both mentioned about Seattle's teaching that the person that is the provider sitting in the driver's seat, not the driver's seat, the passenger seat of the vehicle, first on scene arrives with gloves on, and their job is to beat feet directly to the patient and assure that we have immediate compressions going and that kind of thing. So putting lighting a fire figuratively. So just to keep on going here, Jim, how much do we have? A minute or two left? Where are we at on time? We good?
I think you have about 5 minutes.
Oh, good. So to Dr. Salih, and I'm curious from Leslie's perspective then as well, this pandemic that has been such, catastrophic on our nation and the world, do you have any sense from your work, Dr. Salih, on how that has elevated EMS as part of those work frontline responder heroes? And do you think we can somehow capitalize that on recruiting? And Leslie, just similar kind of thoughts from an administration perspective from EMS.
Yeah, I think certainly it has elevated, at least in some ways. I know that many of us have, particularly in this, simultaneously felt the spotlight on us, but also perhaps not supported in certain pieces. So it's a bit of a double-edged sword, but absolutely, I think that with the spotlight on frontline providers and EMS, I feel like the conversation certainly has changed in the communities in a good way. And I think now is the time, really, there's a fantastic conversation that I kind of keep looking over to in the chat about really advocating for our EMS providers as a career rather than as a stepping stone, and using that as a pathway really towards investment in training and providers, but also resources as our first and most critical potentially piece in cardiac arrest. So I would say yes, absolutely. And I think the idea to take advantage of it to really support our colleagues in the field is really important.
I would agree. I think EMS is definitely having a moment through COVID. It's really raised the specter of how much, capabilities they have in the field that maybe the general public doesn't know. And we've seen a big increase on the recruiting side. We have somebody that focuses on high schools and healthcare consortiums, and we can't even fill, we have a big overflow to our classes. We want to add extra EMT courses. So I think this is all a good sign for EMS.
Very good, thanks. So just in a couple of minutes we have left, let's try to do a little rapid fire clinical response. So, and this is probably more for the clinicians in the group, but or former clinicians or whatever. But let's start with advanced life support airway management, endotracheal intubation versus supraglottic versus something else. I don't know, crike or something. Real quickly, Rob, what do you think?
Okay, well, I think that for most of the time, super or extraglottic airway should be our first choice. If you're doing intubation, you really need to have a top-notch quality improvement program. And you know what? That's just as true for us at the hospital. So, if you look at it, right, the consensus data out there is everybody should be using video laryngoscopy, right? We don't talk about that sometimes, but now there's 3 large-scale trials showing that, it improves outcome.
Yeah, good. Couldn't agree. I think people know how I feel on that. Luke, thoughts?
Kind of agreeing with Dr. Dunn here, which I often do. Supraglottic airway is going to be typically a faster intervention. There is skill degradation when new technology comes in. So maintaining intubation skills is challenging for a lot of our systems. Integrating, even from just as efficiency and safety aspect, automatic compression devices. I know there's controversy on outcomes, but we can certainly talk about efficiency and ROSC and provider safety. So there's some benefit there as well to look at going forward.
Okay, Emily, not wanting to put you on too much on the spot because we are in the process of revising our protocols, but as a very seasoned paramedic, any thoughts on where you'd like to see airway management go?
So I think that especially in relation to cardiac arrest, everybody has said it already, supraglottic is the better way to go. And we know that all the evidence shows that we need to focus on, the actual compressions. And I think that honestly, all of the work around intubation distracts from the primary objective when we're talking about a cardiac arrest. We know that, and we just have to get over that resistance to change that paramedics have.
Yep, resistance to change. Got to move forward. And I see we have a new slide up, which I think is Jim's subtle way of saying our time is come to an end here. I think we covered one of my several clinical topics. Luke briefly touched on mechanical CPR, and I think there's schools there that are strong advocates and strong opponents, and people in the middle, I guess. But I think we still have a lot of questions about that. So as we move forward at the state level with our next iteration of state protocols, I think if you have thoughts about particularly the clinical protocols, certainly try to get those to Emily or to me. We'll put our email addresses. They were on the earlier slide, but if Emily's willing to do that, we'll put that in the chat as well, and I'll put mine in there. Jim, back to you.
Thanks, Bill. Thanks for leading this great discussion. And if anybody wants to get a hold of Bill or Emily, you can always email myself or Terry as well, which our emails are in the next couple of slides. Just to summarize real quickly, really focused on, advocacy and support for EMS and trying to increase, personnel. I think one of the ways we might be able to do that is, taking advantage of, all the things that first responders have done for us in the limelight in the last year, and maybe have a message campaign, really highlight what they've done and the support that they give us. So we need to give that back to them. Try to do some debriefing, maybe with a toolkit, training focus on CPR. So when a rig arrives to the scene, things in their head are CPR related, and then talk about airway kind of issues too. So we'll kind of go back through this discussion, post those things on our website. I really appreciate the discussion and everybody's thoughts. I just want to kind of end the talk today. I want to emphasize that this work will not get done alone. We need everybody's help. So please visit our Save My Heart website or contact Terry Shields or myself if you want to become more involved. Those are our emails there. And again, we can loop you into any of the speakers. It is our hope that next year's conference will be in person and focus on the accomplishments of the tasks that we identified here in this conference. So all the to-dos that we've gotten listed here today, let's go out and do those things so next year we can talk about how well they worked. I want to just take a moment to thank all the speakers and panelists who've shared their time and knowledge for today's conference. You see the speakers there, and the panelists really appreciate your time. Could not have done this without you guys. Also want to thank and take a special moment to thank our survivors and rescuers who have shared their amazing stories of survival. This is really why we do this work. You know, it's those 537 lives that were saved last year. That's why we do this. And I want to thank all the survivors and rescuers who are on the calls as participants as well. Just great to have you with us as well. And then finally, I want to take a moment to thank all the Save My Heart committee. Volunteered endless hours, putting up with my time, restrictions and things like that to meet on a very frequent basis and putting this together. Without their dedication, this does not happen. I want to thank all of you for attending our 6th annual Save My Heart conference. Together, we can continue to make progress towards increasing survival of out-of-hospital cardiac arrest. Additional questions or additional answers to questions that were posted on today's call will be on our website shortly, along with recording of this conference. Please be watching Save My Heart email in the future to discuss opportunities to help any action items that are identified today. And finally, please complete the survey for this conference, which you can find in an email that will be sent to you or in a link in this chat. I just want to thank everyone and then be safe. And with that, we will conclude our conference and see you guys soon.